Well, good morning, everyone. All right, everybody awake? Maya, you had your coffee. I saw Maya walk in this morning, and she's staggering, so I quickly ran and got her a cup of coffee, and she's now all juiced up and ready to go. So, welcome to the third annual Motown Women's Heart Symposium. You know, the elephant in the room is Dr. Nishta Serene. She's the one that put this entire program together. So Nishta, thank you for putting this together and putting an amazing group of speakers from Mass General, Yale, Providence, St. John, Indianapolis, from the entire country. So thank you. We've got Dr. Rodriguez here with us today from our Ascension, Tennessee market. I'm used to saying Michigan. I've got to get out of that habit. So anyway, welcome all of you to the Motown Symposium. We're really thrilled and honored. We've got Dr. Ed Fry, who's going to come up and say a few words. Ed is the past president of the American College of Cardiology and is the lead cardiologist for the entire Ascension, Michigan service line. And what a privilege and an honor to work with that. If I was in that role, I'd be pounding my fist, and I want this. He gets the same thing done without any, I don't know how he does it, but he gets it done. And he oversees like 140 hospitals as a service line, and he does it with a lot of grace. He still practices, sees patients, runs a heart hospital, and in his spare time is past president of the American College. He just arrived last night from Japan, and he's on the Trump Kamala Harris circuit if he's trying to hit every state in the next 30 days. So Ed, thanks for being with us tonight, and I'll have you come up and say a few words. And thank you all for being here today, and obviously grateful to be here. We also have Dr. Aneth, who's the president of our ACC Michigan chapter, here with us today. Dr. Aneth, thank you. And Dr. Sunil Rao, who put on a fantastic symposium in northern Michigan at the Grand Traverse Resort. If you've never been to Michigan, Michigan is an absolutely beautiful state, Nishta, and not Tennessee, okay? And Michigan is, especially northern Michigan, is just incredibly beautiful. And so you got to really make time. And Dr. Rao put on a beautiful conference up at the Grand Traverse Resort. We enjoyed it immensely. So thank you, Sunil, for all that you do here in Michigan. All right. I'm sorry? And, oh, Dr. Abadov, of course. Both of you put it on together, so thank you so much. All right.
Well, I'm not nearly as prepared as Shukri is. Well, I will just be very informal and just say a few things. And again, can't thank Dr. Serene enough for her contribution to not only this program, but her work throughout the Ascension, Michigan ministry, and really bringing women's cardiovascular health to the appropriate level of attention and development that it deserves. You know, in the programs that I attend often, I really sort of focus on the area of care transformation these days, and talking about care transformation. And as part of that, talk about the sort of the good and the bad where we are in cardiovascular medicine. And given that the theme here is the Motown theme, I wanted to try and see if there were some Motown lyrics that might sort of reflect that. And a little less uplifting song, but Marvin Gaye's What's Going On, one of the lyrics in it is, what's going on? We've got to find a way to bring some understanding here today, what's going on. And I think that's what we're doing, is hoping to have some understanding and bring that to everybody. So when we think about the state of cardiology, we have this tremendous, somewhat imbalance of amazing successes, but daunting challenges. So the successes are obvious. You know, what we do now with transcatheter therapy is really transforming valvular heart disease to a non-surgical method of therapy. What we can do with complex PCI. There's really very little, and I would defer to Dr. Lansky, who's obviously going to talk a little bit about this, but there's really probably very little that we can't do without catheter-based therapies for the management of coronary disease these days. And when we look beyond that with medical therapy, look at where guideline-directed medical therapy for heart failure has gone, really transformed heart failure from a disease process as lethal as cancer to one that is a chronic disease that we manage in an outpatient space on a regular basis with amazing drugs, including the diabetes drugs that have really become cardiovascular drugs wrapped up in diabetic wolf's clothing. And then we look at where we are with prevention, and we're just on the precipice of the explosion of using short interfering RNA technology to really create vaccines against LDL, PCSK9, and lipoprotein A, as well as hypertension. Treating hypertension with siRNAs directed against angiotensinogen. Isn't it quite remarkable that people in their 20s and 30s, they'll be getting vaccinated against these cardiovascular risks going forward? This will be transformative, is transformative, and we see those trials going on right now. But then, and then disease, we're actually changing disease. CRISPR technology. We now have technology that we can actually change the basic underlying disease process and things like amyloidosis with CRISPR. That is radical. But with these great successes, we also have challenges ahead, and they really boil down to two categories, two areas, I think. One is disease burden and demand that we place on the cardiovascular system, and the other is the correlate, which is the workforce issue. And we have this, these two things are direct loggerheads. We have rapidly growing demand. We have a huge number of people with diabetes and obesity. It's estimated by the year 2050, 60% of adults will have hypertension, 50% will be obese, and a third will have diabetes. That 2050 is not far away, so we have a lot of work to do. At the same time, our workforce is being challenged. We're aging just like the population is aging, and people are leaving the profession, both by choice as well as by retirement. And in fact, in cardiology, we are training fewer trainees coming into the profession than who are exiting through retirement. So we have a net loss of 500 cardiologists per year nationally. And when you look at that over a 10-year period of time, that's 5,000 cardiologists at a time when the disease burden is going up. Not as a direct result of that, but one of the challenges in front of us is that our longevity is declining. Some of that is an aftermath of COVID, but the other half of it is really some backsliding that we have done in terms of the successes in cardiology. So we're seeing mortality rates go up because of this disease burden. Now, what are we going to do about that? And on the workforce standpoint, obviously there's some things we need to do in terms of we need to train more cardiologists. We train fewer physicians in the United States than on a per population basis than any other developed country, 2.6 per thousand as opposed to the average of 3.6 per thousand. We also have people leaving training. A quarter of trainees in fellowship don't go on to clinical practice. They go on to other opportunities. It's not to say that their training is not valuable. In fact, these are the people who very likely will be the innovators and bring new ways of doing things to the bedside. But people are going into work for AI companies, or work for biotech or pharmaceutical companies. We have to leverage team-based care, and many of you who are here today are valuable members of the care team, and we need to leverage that in the most efficient way. And we have to need to build on our successes with innovation, both AI as well as other technologies. We also need to have our workforce look like the communities that we serve. So we're going to be talking a lot about women's heart disease here today, but we also need to be talking about women in cardiology. Today, 10% of practicing cardiologists are women. Now the good news is We see a steady increase in the number of women going into internal medicine, steady increase in the number going into fellowship training. And I'm proud to say that at last year's ACC and in awarding FACCs, a third of the new FACCs were women. So we're making progress, but this will be generational. It will take generations for that to catch up and reflect the population. We have a lot further way to go when we reflect the other important aspects of our community. Black cardiologists, Latino cardiologists, people from underrepresented communities who have not had professionals in their family now becoming cardiologists. So we really have to work hard in that regard. Lastly, I'll just say one thing you'll hear a lot about today, and this is really, I think, a critical issue and something all of us can do something about, and that is the epidemic of maternal mortality. And maternal mortality is cardiovascular mortality. More than 50% of maternal mortality is related to cardiovascular disease. And although a lot of the solutions are medical, a lot of the solutions are non-medical, non-clinical. Their access to care, their prenatal care, their support of screening for risk factors. And these are things that will come not just from the medical community, but also through advocacy. And so I'll just close with saying that as you think about how we improve women's cardiovascular health and their care delivery, think about advocacy. Think about how do we change the environment that we're in from a regulatory and legislative process to improve that access to care and to improve those outcomes all across the board, not just men, not just adults, but thinking about women early in their lives and improving things that way. So I look forward to the rest of the program, and congratulations to everybody. Thank you, Shukri, for supporting this process.
Thank you, Dr. Fry. That was very eye-opening. Very well taken. Representation of women in cardiology, and Dr. Alexander Lansky, who's our national keynote today, has been a champion in it from Society of Cardiovascular Angiography and Interventions, promoting women engagement in cardiology and interventional cardiology and promoting them. We also have a faculty, Nadia Sutton, who has done phenomenal work in this realm. Dr. Claire Duanois, who has also done phenomenal work in this realm. So, point very well taken, and thank you for that beautiful address, Dr. Fry. We really appreciate you. We're honored with your presence today. Please can I invite Dr. Karthikeyan Anthasubramaniam. He is the governor for ACC Michigan chapter. ACC Michigan chapter has endorsed Motown Women's Health Symposium 3rd year in a row. Dr. Anand is also the director of PET-CT echocardiography and also directs the Imaging Fellowship for Henry Ford Bloomfield Hills. Dr. Anand.
Good morning, everyone, and again, welcome to the 3rd annual Motown Symposium. On behalf of the Michigan chapter, we are again delighted to collaborate and co-sponsor this symposium for the 3rd year. For those of you who were there yesterday, I did mention Nishta and me go way back. So I'm just so proud to see of the accomplishments that she has actually done here. I do want to highlight the key aspects that she has collaborated with the Michigan chapter to actually promote women's health. Nishta joined the chapter and we invited her to chair the Women in Cardiology position and council at the chapter. This is my 3rd year as the governor, and I'm outgoing, and it has been truly a delightful experience. But a large part of that is working with passionate leaders who care about cardiology, but more importantly care about women's health and women's cardiovascular issues, and Nishta has been a champion for that. She secured the chapter section grant through the ACC for the women in cardiology and put together some fantastic, informative, eye-opening series of lectures highlighting aspects not only for women patients but also for women cardiologists who deal with daily challenges during their practice. Whenever I meet with my chapter executive, when we meet every 2 weeks, my chapter executive always says, Dr. Anand, Dr. Serene has a new idea. Dr. Sareen wants to do this, Dr. Sareen wants to do that. And I said, when does she actually sleep for us to be able to actually, satisfy all of the stuff that she can do? So really, just a fantastic woman and a leader. Unfortunately, we're going to lose her. But as some of you heard yesterday, the chapter wanted to felicitate her accomplishments, and the nominations committee voted for her to get the Heart of Cardiology Award, which will be awarded to her in person in 2025. So I want all of us to give a round of applause for her. And so from the chapter standpoint, we are delighted to actually collaborate with this. Thank you, Nishda, for your invite and for your hard work for the chapter. And I want to make a pitch for all of you here. You're all here because you care about women's health. And many of you are women leaders and cardiologists and physicians in practice. So the chapter is always looking for young, energetic, upcoming leaders like Nishta. So I encourage all of you to join the chapter or bring your ideas to the chapter. And it's an open forum, so you can reach out to me or to my chapter executive, and we'd be delighted to have you as volunteers working for promoting women's health in Michigan. Thank you very much.
Thank you, Dr. Anand. I'm not sure if I'm deserving of that award. It's been a great leadership and a lot of promotion within the chapter, for sure. Being a part of the chapter, contributing to it and learning from the leaders is a great initiative, and I would urge everybody to enroll in PSBAs, physicians, and fellows. I would move on to request Dr. Evelio Rodriguez. He is the Ascension Tennessee Market CV Service Line Director. He's here visiting us from Tennessee. Dr. Rodriguez, please can we request a few words from you?
Good morning, everyone. I would say that I feel a little bit bad about this because I've been called a thief. I've been called the person who came and stole her. And I wasn't prepared for this. And unlike Ed, who says that he was not prepared, I really wasn't prepared to speak here. No one is not prepared in pools like Marvin Gaye's songs, So I'm honored to be here, and I'm honored to be the one who is taking this to Tennessee. Like I was telling people yesterday in the event that we had, which was amazing for those of you who were not there, it was an amazing event to see in only 3 years what someone has been able to accomplish. And I know Nish has done a lot of it, but everyone who's here is responsible for that. I was just sitting on the table and they showed me this. You guys have this in your tables. I would encourage you to take a look at that. I've been with Ascension for 12 years. I don't think there's anyone who in 3 years can accomplish something like this in such a big kind of enterprise. So you should all be proud of this. People were saying we're losing her. You are not losing her. She started this program with you guys. She will still be here with you forever. And the fact that she was here for this many years and the ability for her to go to a different state and do the same thing, we all should be proud of that, and you should be proud of her doing that, and be happy for her and happy for me. I'm also very happy because my wife is a breast surgeon and she is a promoter of women's health, and she is probably happier than me that Nish is coming. So again, I know it's sad for you guys. It's very happy for us. We should all be happy. Be proud of her. I really appreciate Shukri and the great, he gave me a tour of Birmingham yesterday in an hour. We, I don't know, went to 5 different places and walked the whole town. So I appreciate how kind you have been to me, and this is an amazing event. Thank you, and I guess, can we get started?
Thank you, Dr. Rodriguez. That was very kind. I'm very honored and very humbled to be a part of Ascension, Tennessee, which is a very accomplished market, and I'm sure we'll be able to achieve great things there, especially with your leadership. Please can I request Dana to come up here and give us some housekeeping rules. We'll be starting our CME program. Just a couple of reminders. Please keep your cell phone on vibration during the program or on silent. There is a speaker who's going to be doing the working lunch at 12:30. It is Dr. Maya Sarhal. She's an interventional cardiologist and endovascular interventionist at NGH. And she's going to be talking about interventions for VTE during pregnancy. Please can I request Dana to come up on the stage and give us the housekeeping instructions. Thank you.
Welcome to Motown's Women's Heart Symposium. We want to again thank the American College of Cardiology for endorsing this program today. But also we couldn't do it without our many sponsors. So today during your breaks and as you leave the CME room, please go speak to our sponsors. Without them, we could not put on these kinds of programs as they are existing today. As Dr. Serene mentioned, please put all of your phones on vibrate. If you must take a phone call, please exit the CME room and take it out in the hall. We have many that are joining with us online today. I'm asking them to use the Q&A feature located within Zoom to ask any questions that you may have. And then also I am monitoring the chat feature, so I will be able to communicate with you just in case there are some technical difficulties. Now for all of you that are wanting CME, this is the next important slide. Please, right now, pull out your phone. First, I want to say that QR code, do not use it. The only way that you can use that QR code is if you have already downloaded Cloud CME on your phone. Otherwise, it takes you to some strange website, and I certainly don't want that on your phone. But what I do want you to do, those of you that do not have Cloud CME currently on your phone, open up your text messaging app on your phone. What you would normally use to text message anybody, and start a new text message. And the phone number that you're going to put in the to section of that is 844-924-2995. So that would go in the top section. And then in your message, all you need to do is enter the phone number, or enter the ID 22573. Now, once you hit send, if you did everything correctly in your profile setup, you'll get a thank you message and your evaluation will be there. Please take your evaluation within 10 days. Let us know how we did. Tell us how our speakers have done, and let us know what you want to hear us do in the future. If you receive an error message, possibly in your profile you did not set up your mobile phone number, I can help you do that during today's conference. I am located at the IT desk off to the side. I'll be happy to help anybody that has an error. But again, that phone number, just in case, 844-924-2995. And the message is 22573. Now, building this conference today, we had many helpers and many speakers. Most of us today have no relevant financial relationships with any ACCME defined commercial interests. However, Dr. Anand, he receives grant funding from Astellas and Bristol Myers Squibb. And then Dr. Hohenberg has consulting fees from Biopharma. He is an advisor for Mega Health and receives grant and research support from Genentech. Dr. Lansky receives consulting fees from Biomed and Boston Scientific and Research and Grant Support from a biomed. Dr. Mehta receives grant support from Abbott, and she is on the speaking bureau for Abbott. And she also receives grant support. Dr. Serene receives consulting fees from Abbott, and Dr. Sutton receives consulting fees from Abbott and honoraria from Zoll and Phillips. However, all of these disclosures have been mitigated, and today's conference should have no bias in your CME credits. Again, you have about 2 hours after today's conference if you did not submit that code yet. Otherwise, you have 10 days to complete your evaluation. Once you complete your evaluation, your certificate will be immediately available to you to download for your use. Again, thank you for welcoming me to Motown and allowing me to support this program for CME.
It's my honor and privilege to introduce our first national keynote speaker, Dr. Alexandra Lansky. She's Professor of Medicine at Yale School of Medicine, Director of Heart and Vascular Center Clinical Research Program, Director, Yale Cardiovascular Research Center. She is the Editor-in-Chief of Journal of the Society of Cardiovascular Angiography and Interventions, a great interventionist, very talented, and promotes women, and we owe her our careers and our trajectories. Thank you, Dr. Lansky. And Dr. Lansky is going to be talking to us about gender disparities in healthcare.
Real quick, I did forget to mention, we have Beth in the back of the room. She will be our timekeeper, so when you see a yellow card, that means you have about 2 minutes left. And then a red card means that we need to stop the lecture and move on to the next.
Thank you so much. So Nishta, thank you so much for having me here. Thank you everyone for the great welcome, for taking me around Birmingham last night. Maybe a little bit too late, but bear with me this morning. It's wonderful to see everybody here. So gender disparities in cardiovascular healthcare. I've been obviously in the profession for well over 2 decades. This is something that has been very close to my heart for this period of time. It's not the only thing that I've focused on, but I think there's some important things that we need to address and talk about and be aware of. And I have to say I'm very impressed by the program that Nish has put in place, and I can certainly understand the feeling of losing you is going to be a big shoes to fill. And I suspect it's going to take several people to fill that role. So here's some conflicts. Again, I don't think this is going to impact what I'm going to be talking about at all. I'm going to start with this. So cardiovascular disease is still the #1 killer of women in the United States, claiming 1 in 3 lives. And around 400,000 deaths on an annual basis. I came out of my fellowship. I don't know if I have a pointer. Does that show? Yeah. So I came out of my fellowship at that time where there was the greatest difference in mortality, excess mortality in female patients. That was late 1990s. And at that time, primary prevention thresholds were different for women. Lipid levels for primary prevention were at a different scale for women compared to men. That has changed. The decrease that we've seen in cardiovascular death overall for both men and women have been primarily driven by primary prevention, improvement in blood pressure treatment, improvement in lipids, smoking cessation, etc. And you can see that there's been a dramatic decline in the mortality of both men and women. That's the good news, but an acceleration for women. What's a little bit disconcerting is that slight increase that we're seeing. So we're on sort of an upward trend here. I'm not entirely sure what that's all about, but I think we need to keep an eye on that. I think that's one of the key things. I'm going to talk about some of the disparities that we continue to see access to procedures, access to diagnostic procedures, differences in the enrollment of patients in clinical studies, some of the lack of evidence that we have for our female patients. So I'm going to approach this by a series of problems. I should have probably said challenges rather than problems. Problems is probably not the right word. But there are a number of challenges that we face and that we need to address. And I think the first one is about our profession, and Dr. Fry spoke about this, but we don't have enough women in the profession. It's wonderful to see Nish leading this program here, but we simply don't have enough women in cardiology. You can see from this opinion that was published in Circulation, it's going to take decades, if ever, to narrow that gap, right? So this is our reality. In interventional cardiology, there's less than 5%, maybe 7%, depending on who's doing the count, of women in the field, right? So absolute underrepresentation, and we need to recruit and retain women to the field. There's no reason why that's not the case. Athena Pappas published this. Women are 3 times more likely to experience discrimination in the workplace. And I can tell you, I've been in the workplace for 25 years. It's a reality, and it doesn't happen once, it happens multiple times. You have to take it with a smile. It's not funny, but this is a reality. Doors are virtually closed for female cardiology leadership positions, right? So we need to open that up. We need to make it accessible for women to recruit them and retain them. I think that's a really important thing. And there's a critical need for women cardiologists to lead clinical studies and academic themes and topics. So I think that's really critical. So that's on the professional side. Problem number 2 is the patients. Patients in our country do not really understand the symptoms of cardiovascular disease. This is a survey that was led by my colleague Colin Krumholtz with one of his postdocs. And extrapolating, he's basically showing us that 13.5 million people in this country cannot name a single symptom of a heart attack. We need to do a better job. We've done a good job, right? But we need to do better. We're not there yet. So we need to get to patients, we need to get out there, and we need to educate people on the symptoms of cardiovascular disease. Now, when it comes to women, it's even worse, because women, as we know, have atypical symptoms. Some, in the context of myocardial infarction, about 7% of women don't have chest pain, so they're asymptomatic. That leads to delays in presentation. They need to recognize that if they have shortness of breath or other symptoms, they need to come forward. But this is a major, major problem on the patient side. So we talked about the professional side, the patient side. Now, the first point of entry, the emergency room. It turns out that ED doctors, and this is not a blaming game at all. This is just the evidence. Where do we need to fix the problems to improve, the outcomes and access to care? So it turns out that ED doctors don't triage minorities and women as well as they do men, for whatever reason. Maybe its symptoms are different. Whatever the reason is, women are not getting triaged as well as male patients, and they're not getting referred into the appropriate cardiology service, and we know that that leads to higher readmissions. We know that that leads to worse outcomes. So we need to focus not just in cardiology, but we need to pull in emergency room doctors and help them understand we need to do the EKG, we need to do the troponins, we need to do the lactate levels. I mean, this is absolutely incredible. In STEMI, we see absolute disparities in lactate levels that are measured, right, between male patients and female patients. Female patients don't get it. So that's a problem. Now, clinical trials. This is close and dear to my heart. I do a lot of clinical research. But we know across the board in cardiovascular clinical studies, we're seeing a minority of female patients being enrolled. 78 FDA PMA applications. These are pre-market approval. These are studies that lead to approval of devices, right? 33% female representation. And, you know, we don't stratify based on sex. So when you have 33% of females in these trials, you really cannot compare, you know, treatment to controls because they're not randomized. We do not have appropriate evidence for our female patients in PMA trials, but outside of that. And in our field, in interventional cardiology and cardiogenic shock, we just saw the results of the danger shock. It's less than 20%. And we cannot make any inferences from the evidence that we have for female patients. We simply don't know whether the outcomes that are, you know, evidenced in male patients are really applicable to our female patients. This is a huge problem. This is market research trying to understand what are the barriers. And there is no question that women have a very different approach to decision making. And we need to incorporate this. We need to process this. You know, when we do clinical trials in the cath lab, whether it be, you know, a stent study or whatever it might be, you know, the patient is scheduled to go to the cath lab. We're in the holding area. You know, the coordinator goes to the patient. They run down inclusion-exclusion criteria. The patient's a candidate for the study. Will you sign, you know, this is the trial we have. Will you sign at the bottom, you know, we want to do this trial. So for men, they have no problems with that. They say, yeah, that sounds great. I'll sign on the dotted line, enroll me, I'm fine with that. For women, they're stressed. You know, they have a procedure that you know, is going to happen in 10 minutes. They need time to process the information. They need to understand what the impact is going to be on their family, on their kids, on their parents, and whoever they're, you know, caring for. And they need time to process that and to consult with family members. We do not approach the enrollment and recruitment to clinical studies in an appropriate fashion for our female patients, and we need to change that. And we're working on that. Problem number 5 is there have been huge efforts, whether it be NIH, FDA, AHA, the societies. We have taken a lot of attention on this, a lot of different initiatives, but it really hasn't moved the needle. And I think what we need, particularly on the FDA side, I think we need to mandate some benchmarks. Until we do that, just raising the issue and showing that there's a problem is not going to change anything. It's going to change it slightly, but it's really not going to have the impact that we need to have. So we need to keep on pushing on this. We need to, you know, put some benchmarks that we have to follow. Problem number 6 is that this is, as we know, it's not just about women, it's about minorities. I mean, the issues with African Americans in this country are egregious. When we look at TAVI, access to TAVI, the outcomes after myocardial infarction in African Americans in this country, Hispanics, we need to do a better job. It's not all about the healthcare providers. Of course, the healthcare policy is, you know, I think, underlying all of this, but we need to do a better job. And we need to provide, you know, treat these patients, have mechanisms within our healthcare systems to access these patients, and also we need the evidence to better understand the outcomes in these patients. All right, so even when women are treated, they get less advanced treatment, right? So for whatever reason, for instance, CRT, and this is across the board in cardiovascular medicine, so CRT, they get less CRT despite the fact that we know that CRT may be more beneficial in female patients. There's less counseling for primary prevention. Minorities, it's even worse, right? So they get much less counseling than white patients. ICD use is much lower. For women, coming back to interventional cardiology, with myocardial infarction, what we're seeing is younger women, and we're seeing greater disparities, right? So women get fewer diagnostic caths, and it could be, again, the symptoms, differences in symptoms. Fewer diagnostic caths, less primary angioplasty, and as you can see here on the right, women with cardiogenic shock for decades have had less mechanical circulatory support. Why? When you talk to people, it's, well, there's more vascular complications, etc. But that has changed. That has changed. But we're still seeing these huge disparities. And withholding primary angioplasty and withholding mechanical circulatory support, this forest plot, are precisely the predictors of increased mortality. So we know that not treating our women is going to lead to a higher mortality rate. Yet we still don't give them access. Women get less aggressive treatment. This is looking at a patient population with cardiogenic shock, looking at the differences between men and women. And it's really interesting. First of all, women, as I said, get less lactate levels. So we're not doing, we're not diagnosing cardiogenic shock early enough. What we tend to do is to increase the inotropes. So women will be in the ICU, blood pressure is dropping, we get the first inotrope, we maximize second inotrope, third inotrope, and only then do we start thinking about mechanical circulatory support. We go to balloon pump. So we go to balloon pump much more frequently in female patients than male patients before going to, as the case was yesterday, Impella. So that's a problem. When they go on mechanical circulatory support, what's really interesting is that the duration on MCS is much shorter for female patients than it is for male patients. Why? I think that's a big question, but that's what we see. That's the evidence. And in contemporary series, we're not seeing huge excess in bleeding. In fact, in this particular series, it's a post-market study, seeing no difference in bleeding rates. That said, what you can see is that the survival rate, so look at the last bar there, I don't know if I've got a pointer, the survival rate for women that were on 2 or more inotropes is 20%. 80% of these women will die, right, if you delay treatment, right? If you escalate the inotropes, will die compared to 42% of male patients. So this has got a direct impact on their survival. It's not a good situation. This is, again, looking at delays. This is a series, again, post-market study looking at Impella use before the procedure versus during or after. Do we wait for the patients truly to crash before we put them on mechanical circulatory support? You can see that half of women will wait, and that there is a tremendous impact on survival. Whereas for male patients, typically we're treating them up front, and it doesn't seem to be as impactful mortality rates. So again, delaying therapy is really not the best option for our female patients. All right, well, that's all the bad news, right? So let's talk about some happy news now. So the question is, can we move the needle? And what are some of the initiatives that are going on? And I'm going to speak about this from my perspective and some of the work that we've been doing. So I think we have been moving the needle. I think there has been a lot of change in the country. We've seen women health programs, we've seen trials in the space, we've seen documents and guidance documents on this, and I think that, there clearly is a lot of change going on, but I think that we can do much better. So what do we need to do? I think first of all we all need to work together, as we do, but we need to focus on this area and this topic. We need to recruit more female cardiologists and retain them. And we need to open up those leadership roles. As difficult as it is, we need to open up the leadership roles for women to encourage them to come in. If there is no ability to get promoted, they're not going to come. Patient education, I think these are the societies. And again, I think AHA, ACC, SCI are doing a very good job, but we can do better. Clinical trial evidence and guidelines. We have a lot of work to do. A lot of work to do in this space, and I think we need to catch up. So what we're seeing now, and I'll show you a few examples, is we're seeing female-only studies to fill in that gap, right? And bring us up to date, up to speed. But going forward, ongoing clinical studies really need to increase the number of women. I would even say we need to stratify randomized clinical studies based on sex, because we need to be able to say treatment A versus treatment B among women and among men is good, better, not, worse, etc. And we don't have that. And sex-based analyses, I think we're doing them. We're seeing them. I can tell you that there's a lot of resistance. So as we do a lot of sex-based analyses and sub-analyses from clinical studies, and we try and publish those, the comments from the reviewers, it's blinded, so you don't know who's giving you the feedback. But the resistance, this is yet another sex-based, analysis. When are you going to move on? But they're really important, and I would say for all of you in the room doing these, you should not be discouraged when you get that pushback. You have to keep going because it is important. Professional engagements with societies, journals, meetings, I think we've done a huge step forward, huge job in bringing more women to, and engaging them, and I think that just needs to keep going. Industry engagement. I think we have a lot of work there. Industry is driven by, its revenue, right? It's return on investment. Is it in their favor to recruit more women? Well, what that will mean for their clinical trials is they need to extend the duration of enrollment to meet the quotas. So we need to really put pressure on industry and I think that's the role of FDA, particularly in the approval trials. And then regulatory engagement, I think the FDA is very much engaged in this, but I think they need to go to the next step where they say, here are the benchmarks. We need 40% female enrollment in the study at a minimum to be able to assess the safety and efficacy in female patients. So very quickly, I just want to show you some examples. These are just a million papers have been published on the topic. Highlighted in red there was Rob Harrington when he was president of the AHA, writing an editorial. Roxana Mehran with the Lancet Commission. Again, a landmark document really addressing some of these issues. Again, very quickly, I want to show you some of the things that we can do to actually move the needle. So this is a SCI document. It's a multi-society document addressing, it's a consensus statement, addressing treatment issues for women with cardiogenic shock. It's leveraging the SCI shock classification. We are specifically for each one of the stages saying this is what you need to do in women. You need to check the lactate, you need to use a PA catheter, etc. And I think this is going to be very helpful because it gives us a roadmap of where the gaps in evidence are. And I think there are many gaps in evidence. We don't have randomized clinical studies, unfortunately. This is another consensus document that I was involved with. Many of us within SCI were involved with this. And again, I think the benefit of doing these documents is identifying the areas that are gaps and where we need to build the evidence. And I'm going to show you, that was published in January of 2022. Since then, we're 2 years after that, there have been a number of clinical studies that are addressing some of those gaps. This one, the Roma women, is looking at bypass surgery. It's going to be single versus multiple arterial grafts in women, led by Mario Gaudino and Steve Freems, addressing that mortality, the excess mortality in female patients. It takes them a decade to get to the same level of mortality as male patients. So that's going to be an important one. Recharge women, again, another study in women only, looking at PCI versus bypass surgery. And that's on the backbone of a meta-analysis that shows that women with multivessel disease actually do better with bypass surgery than they do with PCI. So, you know, if that's the case, we need to better understand so that we can treat our patients appropriately. Discover Inoka is a study that we're leading at Yale, looking at patients with non-obstructive coronary disease. As you know, large number of patients coming through that don't have obstructive coronary disease. We're going to be phenotyping these patients, following them for 3 years, and we will understand how best to diagnose the disease, how clinically meaningful it is, and how to treat these patients. And then lastly, this is a direct outcome of our consensus document where there was a complete gap in evidence in patients with calcified lesions. And the only treatments and the only evidence that was out there was based on rotational atherectomy and orbital atherectomy, where women weren't doing well. And you know, we have Shockwave, which is a balloon-based treatment, and nothing had been published in this space. So I managed to get the group to summarize their data. We included it in our consensus, and we convinced the company to do a prospective study in this space to gather enough evidence for females only. And so I'm very happy to say that we're 25 patients short of completing the enrollment. And again, that's in a two-year period of time. So this is one of the successes, and I think one of the reasons why doing these consensus documents is so important. So that's what I have. I'm going to leave you with this. These are two guys and a dog. I started exercising because I had a close brush with death. My wife threatened to kill me if I didn't get off the couch. And you know, what I will say is that I think that women have such a sphere of influence. And again, I think you're a prime example. Thank you very much for inviting me to your symposium.
Thank you, Dr. Lansky. That was a phenomenal presentation. I know we have questions from the audience. We're getting questions online. We'll save them for the panel discussion. At that time, we'll start with the audience here and then go on to the virtual attendees for any questions. Please can I request our cardio-obstetric speaker, Dr. Aidan Abidoff, to talk to us about physiology, risk stratification, and referral in pregnancy. Dr. Abidoff is professor at Wayne State and is the director and chief for cardiovascular services. Thank you.
Good morning, and I'd like to thank Dr. Sarin and the organizing committee for this kind invitation. And it's my honor and pleasure to present physiology, risk stratification, and referral in pregnancy. And you know, the one disclosure is that use of gadolinium contrast agents is still considered off-label use, and hopefully at some point we will get rid of the disclosure. The second one is, this is not something that I do daily, and in this case I'm on the receiving side. I receive the consults, but understanding of this important topic is so crucial for us that I can talk about this hours. And I'll start with the statements, miracle happened. And again, it happened, but just a presentation of this miracle. This is a 30-year-old lady with exertional shortness of breath since age 17. This is probably one of the most severe cases of right ventricular hypertrophy that I ever saw in my life. This lady managed basically to have two healthy babies at age 23 and 25. And this is probably one of the largest seeing PDAs that I saw in a living patient, let alone in a lady that had basically successful pregnancies and deliveries. She did develop severe pulmonary hypertension, so there's a cost for all this, heroic efforts. But again, unfortunately, in most of the cases, this miracle doesn't happen. And another disclosure: this is my first attempt to use AI for the artwork, so this is not a real family, but it's a beautiful family. So the AI basically followed my commands when I just asked to present what happens to the beautiful family if this mom is taken away from them. And it's so tragic. And the way how AI put it, and I really almost shocked when I saw it, it essentially destroys their universe. It covers their sun. It takes away everything. So protecting moms are essentially one of the most important things that we can do in our lives as professionals. And just take a look on this website. It's really sobering data. Take a look what happens with the mortality. And we're talking about 21st century mortality of moms going up. So, and you can see how important, as Dr. Fry mentioned here, is mortality associated with the cardiovascular events. So if we bump them together, it's more than a third of these events is cardiovascular etiology. And majority of these cases would be preventable if we start early, if we educate the patient, if we screen them nicely. And on any phase of pregnancy, we look at the physiological changes, and they are very demanding on the basically body of healthy young woman, let alone somebody who has cardiovascular problems. And as Dr. Lansky mentioned, the access to care and patient education is very important. If patient doesn't know what's going on with them, how they gonna basically alert the medical system, let alone alert the medical system early on, when it's much, much easier to take care of the problem. So, and it should be done at the level of self-education. And we're talking about access, social media. We should be very active. We should be very aggressive. We should go everywhere. We should present our societies should be more aggressive, trying to reach the patients and explain them how to diagnose it earlier, what's the differences in their bodies that they should feel, and they are normal. And the ones that would be considered abnormal or concerning. And unfortunately, we kind of little bit slow on it. We should definitely expedite this work. Now, school-guided education is also very important, and the professionally guided education is important. And the second block is the whole big attempt to make sure that we organize the mess that exists in many places in terms of appropriate prenatal care, balanced diet and vitamins, and probably involvement of dietitians for many aspects of the patients. Exercise, and exercise is very important for the pregnant woman, as it's important basically for any patient. So developing the programs that are specifically focused on needs of pregnant women is important, and again, we're really slow on that. And finally, treatment and basically healthy lifestyle modification with the elimination of factors that can add to the risk. So these are the hemodynamic changes during pregnancy, delivery, and the postpartum period. So you can see how demanding these changes are, with significant increase in cardiac output, and it's one of the few true cardiac output state conditions, the normal pregnancy. And again, you can see what happens to plasma volume that goes up. There's a significant increase in this volume-based parameters right during the delivery time to prevent, probably that's the adaptation mechanism, to prevent the blood loss and fight the blood losses during the delivery. And then you can see how it all goes to normal in healthy women in a short period of time. But again, the changes are really dramatic. They are demanding. Now imagine if it happens in a patient that has basically a cardiovascular problem. So you can see the basic physiology that happens. As I mentioned, these increase up to 50% in preload and plasma volume in these patients. And that potentially can explain many anti-physiologic changes that we see with the cardiovascular pathology. And again, the majority of our societies, they support cardio-obstetrics team in management of pregnant patients, both in a prenatal period, during the entire pregnancy and postpartum. And it really, really takes a village to basically protect. And it's not single patient. In case of pregnancy, you take care not only of a future mom, but also the baby. So you save two for the effort that we typically spend for one. And in this case, in my understanding, our efforts are kind of really lower than we could do. So again, we should work as a team to protect our future moms. Now, the standard classification, how we define the risk? Again, there are several steps, and you can see that the last two, basically, with the intermediate and high risk, would be the ones that require immediate involvement of cardiologists, and they are mostly related to valvular lesions, to heart failure. Basically, valvular lesions, I would say the higher risk would be on stenotic lesions rather than on regurgitant lesions. But the earlier we start, again, earlier we get the success and we increase our safety reasons. Basically, the work on this case would be on several blocks. Again, preconception evaluation, planning, and in this case, it's very important to identify the high-risk patients and basically to explain them what are the problems associated with the potential pregnancy, and if some conditions like severe heart failure, severe valvular lesions that you didn't treat yet, and patients with mechanical valves, maybe you should do some additional planning before the patient gets pregnant. So working on it, involving psychology care. And again, entire pregnancy management should be under the care of multidisciplinary team that I've mentioned. And again, delivery and postpartum, few important points here would be to get the specialist involved earlier, to plan the delivery. So that would be the effort to define timing and mode of delivery, something that is very important and might require our attention. For our fellows, two beautiful works that I really suggest to review would be these two statements that come from AHA and our society. And some of the co-authors of these beautiful documents are here. So I sit on the same table with Dr. Duenwa, so if fellows have any questions, I guess they can approach Claire and talk to you afterwards. But that's how we manage the complex cardiovascular disease in pregnancy. That's a document statement. Beautiful, again, document. It's very illustrative. So again, you go, in this case, by blocks of pathology. So you can basically look at patients with the ischemic heart disease, patients with cardiomyopathy, patients with arrhythmia, and basically looking on more frequent situation in patients with hypertension or potential pre-eclampsia. Now, in terms of management of arrhythmias, very important to remember a few things. Pregnant patient has very similar cardiovascular physiology with increased demand on it. So cardioverting this patient is not a problem. Our typical cardioversion would not influence the fetus. So if patient has significant life-threatening arrhythmias, cardiovert the patient with no hesitation. Now, be very careful with antiarrhythmic preparation. So the beta blockers, and I'm not going to talk much because we'll have the dedicated PharmD presentation, and I don't want to basically compete with my pharmacy colleagues. But basically, considering that the advanced antiarrhythmics may have potential class C indications, so maybe teratogenic, maybe difficult to manage by fetus, even in a breastfeeding period. So consider amiodarone if you need, but it got to be really significant need. But the beta blocker will be something that we should consider first in patients with tachyarrhythmias. Again, cardioversion works, and if you have patient with WPW and basically ablate the arrhythmias that can be ablated, consider it early in planning of pregnancy before the patient gets pregnant. Diagnose it earlier, explain the patient what are the symptoms of recurrence. Now, hypertension, again, just a quick word on that. So the typical definition of hypertension, blood pressure on basically more than one measurement, greater than 140 systolic or greater than 90 diastolic. Now you can see also definition of severe hypertension, and again it's a greater or equal 160 systolic, and these are the ones that we need to really focus and involve multidisciplinary team approach. Majority of these patients will have some situation that we can influence, whether it's diet, whether it's weight loss, whether anything else. Some patients will have secondary cases of hypertension that we can also treat before patient gets pregnant, so renovascular hypertension. Many cases we can also help them to adjust their lifestyle, and basically if patient has sleep apnea, if patient has anything else, treat it before the hypertension gets really bad. And of course, all this influences our ability to treat the patient during the pregnancy and during the delivery time. Now, again, just two words here, because again, I don't want to compete, but basically the beta blockers will be our first line. We can definitely involve hydralazine and nitrates. For the fellows, don't use hydralazine basically alone, because it's not good for cardiovascular, both morbidity and mortality. It can really influence the prognosis. Try to add the nitrates to that. And it's a great treatment, not only just for hypertension, but also treatment for the heart failure in these patients. Unfortunately, in these patients, we cannot use full guideline-directed medical therapy, because some of the drugs like AC inhibitors, ARBs, and so on, they may be teratogenic. Now, I mentioned two words regarding timing and mode of delivery. Few things that, you know, the cardiologists, we're not always involved in these decisions, but we should be, and we can add basically to the shared decision making. So the majority of specialists would support basically spontaneous labor and vaginal birth for majority of women with heart disease. So exclusion from that would be patients, for example, with mechanical valves that are completely anticoagulated with INR 4, 5, 6. In this case, we're talking about risk of bleeding for the fetus also because of the trauma during the vaginal delivery, so you may consider cesarean delivery. However, cesarean delivery per se is known to carry increased risk of infectious morbidity and thrombotic complications. So you should be really careful. Again, timing of delivery, in complex cases, you should plan it in order to provide time when the patient arrives to the hospital in normal time, when you have access to the entire team, and it's not happening at 2 a.m. basically in the morning when there's a mess, when there's half of the team is not available. So you should plan it and do it in the right time and the right place for complicated cases. Now, what is important, I'm an imager, so that's my passion, so just two words regarding the imaging. What was our concern? Well, it's expensive, so that's what societies say recently. Expectation of lower procedural costs should not be reflexively favored. Specifically in cases of pregnancy, we should do our best. So the most important part is prenatal or peripartum spontaneous coronary artery dissection. This is not coronary atherosclerosis. Typically, it's proximal artery. Typically, it's a potentially fatal, life-threatening condition. We should not play games with that. So if you really suspect dissection in the peripartum period, we should do the best to provide the best possible definitive testing. In this case, it's anatomic testing. If you have somebody with troponins, somebody with ischemic EKG changes, don't send this patient for stress test. Don't take a chance. This patient should have visualization of coronary arteries, whether invasive or non-invasive. Now, basically, coronary CTA is perfect for lighter cases. The beauty of this test, it's the highest possible negative predictive value among all the diagnostic tests. So we're talking about 99 to 100% negative predicting value. You get this beautiful image in patient with chest pain, you're done. There's no proximal dissection. However, in many centers, there's no access, say, at 2 a.m. to the normal coronary CTA read by expert. So I would suggest involving our interventional colleagues, considering a quick diagnostic left heart cath in significant cases, again with troponins, with the basically chest pain, with the EKG changes, because the interventionist can control amount of contrast, and sometimes you can finish cath with 20-30 cc of contrast, and it controls the level of radiation that this patient exposed, and potentially protecting the fetus if it's happening before the delivery. That's important considerations that we should apply. Now, overall, the post-delivery follow-up and late cardiovascular risk is very similar to what we do in our typical lives. So now we have time to relax a little bit. Again, breastfeeding is something that we should always consider providing medication support for this patient. And again, taking consideration of the entire block of lifestyle modification is probably as important as treating these patients. Now, you should have probably conversation of potential future pregnancies at this point, because you know, it happened, everything kind of normal, the baby is okay, mom is okay. This is maybe the best time to think, okay, you had, say, an increase in your blood sugar during pregnancy, you had an increase in your blood pressure. How about we treat this? How about we do that? And usually moms will be more appreciative now after they saw what might happen and they have more education. Now, just really one word on contraception. We may be asked, again, there are the conditions that we should be considering. The thrombotic complications, ischemic heart disease, hypertension. Just remember that combined contraceptive medications combining two hormones are not good, and they usually, the risk of using these contraceptives basically may be more than benefit from their use. But again, providing your recommendation for most reliable contraceptive method in patients with severe advanced heart disease is the best that we can do. Explain to the patient that you have postpartum or peripartum cardiomyopathy, you have significant more than say functional class 2 symptoms. You should do something with this, but we're going to treat it, to fix the problem if it's fixable, and then consider it. And again, for this period of time, you should advise on most reliable contraceptive method to prevent possible pregnancies. Literally 2 words regarding heart failure and cardiomyopathies in pregnancy. Now, the ones again that have significant problem, you must involve multidisciplinary care. So everything should be explained to the patient. You should get shared decision making, not just by the team, but also involving the patient and the family. And again, remember that guideline-directed medical therapy doesn't work in these patients because of problem with teratogeneity of some of the medications. Now, remember that cardiac MRI is safe for the pregnancy, especially advanced pregnancy, doesn't do anything bad. And you can see how much definition we have on any cardiac structure on MRI, especially in patients with non-conclusive, basically, other methodologies like echo. This is a stress test. You can clearly see perfusion defect in this patient. No radiation. Again, it's very quick. It's less than an hour, and you get great results without exposing the mom or the fetus to excessive radiation. In any case, you should do anything possible to prevent exposure of mom to all body radiation, so no nuclear test for these patients. Again, hypertrophic cardiomyopathy important, and again, cardiac MRI gives you, so this is normal heart, and that's the hypertroph. You can clearly see changes in the septal architecture. You can have all the recommendations in terms of LVOT obstruction, and it's definitive. So in pregnant patient, go for the most definitive test. And again, if you have aortopathies, this is a 4D flow methodology. You have not only the sizing and anatomic imaging, you can have prediction of increased shear forces in particular part of the aorta, and point out what part of the aorta may be prone to rupture and dissection. So in summary, cardiovascular morbidity and mortality are on the rise, unfortunately, among pregnant patients, and we must do anything and everything to protect health of future moms. To me, it's a crucial task for our society. Multidisciplinary team-based approach is really the way to go. And again, identify your team, work with your colleagues, make sure that the team is ready to act, because the pregnancy is one thing to plan. Deliveries we can plan, sometimes it goes against our plans, so the team should be ready, you should have great tools of communication. We should educate our patient, we should provide them great access to care that is available. The medicine in 21st century, we can be proud of it. We did really long way from, if you remember in Sorbonne, the physicians had to taste urine in order to establish diagnosis of diabetes just in 14th century. So it's a long way that we went. So again, the pregnancy planning, it would be something very important in patients with significant cardiovascular conditions. And if we do all this, so hopefully this nice family will be safe, protected, and we'll be able to see the sunrise and sunset for many years. Thank you for your attention.
I'm Dr. Chris Giuliano, past ACC-CV team representative for Michigan, Professor, Wayne State University, clinical pharmacist, Henry Ford, St. John. Dr. Giuliano is going to be talking to us about pharmacology in pregnancy and lactation. We'll request our speakers to comply with 10 minutes. We have a very packed agenda. I want to make sure we go through all of it today. Chris, we look forward to your talk. Thank you.
All right, 10 minutes, so I'm going to run up here really fast. Good morning, everyone. Today I'm going to be talking about practical considerations for medications in pregnancy and lactation in patients with hypertension, heart failure, and coronary artery disease. So this is 2023 data. There was 3.6 million births in the U.S. It's a lot of births. 1 to 2% of these mothers have cardiovascular disease. Unfortunately, that cardiovascular disease, we've heard this a lot today, accounts for a lot of the maternal mortality that we see. That's 15.5%. So there's three big things I want to talk about today with medications. And the first one is going to be how medications change in the setting of a pregnant mother. The second thing I'm going to talk about is medication risk with the fetus and the embryo. And the third thing that I'm going to talk about is medications in the setting of breastfeeding. So let's move on to the first one. And this is pharmacokinetic changes. So as a pharmacist, when I think about pharmacokinetics, which is a term you guys probably heard last in medical school, hopefully you don't have to hear that on a daily basis. I think about absorption, distribution, metabolism, and excretion. And I'm going to talk about each one of these as it relates to pregnancy. So fortunately, the first one with absorption, it's pretty easy. There's no changes in pregnancy with the mother, unless they're throwing up and they throw up the medication, that's not going to be absorbed, but no changes if it goes down in the normal manner. Next, talking about distribution, this is our first big change. We see about an increased 50% in the total plasma and total body water in pregnancy. What the effect this has is an increase in the volume of distribution of medications, which is a pharmacokinetic term. The practical effect is that that prolongs the half-life. However, we have a lot of other functions that are going to decrease the half-life in pregnancy, and those are the next two we're going to talk about, which is metabolism and excretion. So the majority of medications, metabolism is increased during pregnancy, with the exception of medications that are metabolized by CYP1A2 and CYP2C19. Everything else is an increase in metabolism. And there's also an increase in renal excretion by about 50% in the first trimester. So that's a big change, and that actually increases as you go throughout the pregnancy. The overall effect of medication clearance in pregnancy for most drugs is you'll probably need a little bit higher of a dose because the concentrations are going to be a little bit lower. So if you're using some of our hypertensive meds like nifedipine and labetalol, you may need to be more aggressive with the dosing during pregnancy specifically. Now I want to talk about medication risk in pregnancy. Now when I was in pharmacy school, maybe I'm dating I wasn't in pharmacy school in 1979, fortunately, but this is how medication risk was classified. And that was A is like there's good evidence to support use in this population, X completely contraindicated, and B, C, and D, everything else in the middle. And who else learned about this system in the room? Anybody? Yeah. Now, who has mentioned this system to one of their colleagues in the last 5 years? You can be, yeah, okay, good. And so my big ask today is to move away from the system of using letters. And because the worry and why the FDA changed this is because this gives a lot of a lot of people false reassurances. And the importance is in the details. And so the FDA went to this descriptive method of talking about medication risk in pregnancy in 2015. So if you look at any drug information program, you'll find that it provides a nice description of the available research, which often is not randomized controlled trials. A lot of this is observational data, but you have to make the best decision for patients with the data that you have. And a lot of the time it is going to be observational research. So my big ask here is for you to look at the descriptive risk for the fetal risk during pregnancy. Usually that is higher in the first trimester. We'll talk about some cardiology-specific medications here in a second. Lastly, I'm going to talk about breastfeeding. This is the most important statistic for you to know about breastfeeding is the relative infant dose. That's the concentration in the breast milk relative to the concentration in the mom. And if it's less than 10%, it's generally thought to be okay to do. However, just like any time in life, if you make a rule, there's going to be exceptions to that rule. And so there's not a lot of cardiology exceptions, but valproic acid is an example where you still avoid it even though the relative infant dose is less than 10%. Any medication that gets into your brain and crosses the blood-brain barrier is likely to get into the breast milk is an easy rule to think about when you're looking at medication and breastfeeding. There's different things that can increase the relative infant dose, things like increased bioavailability, increased lipid solubility, smaller size, less protein binding. That makes medications go more into the breast milk. I will mention for the first few days after delivery, the lactocytes are still forming in the breast, and more medications are going to get through into the breast milk. So even if you look at the published data, it might not be completely accurate for the first few days after birth. Now let's move on to our cardiology medications. And apparently my slides didn't transfer appropriately because these colors are awful. But we'll talk about the first class up there, and these are contraindicated medications or medications to avoid. These are going to be our ACE inhibitors, ARBs, ARNIs, and direct renin inhibitors. These can lead to teratogenicity, including fetal death, so we do not use those in this population. We can use them in breastfeeding, specifically ones with a relatively low relative infant dose, and those can be captopril and enalapril. For aldosterone antagonists, we generally avoid because of the anti-androgenergic effects. However, it can be used in breastfeeding as well. Now statins are an interesting one. Statins, when they were approved, they were given the big X. They were a category X when they were approved. I said not to use those letters, but I just did, because that's the history behind it. And so the FDA actually changed the labeling a little bit on this class of medications. They were saying to avoid use in all patients. Now they're saying avoid use in most patients. You definitely want to avoid use in the first trimester. There's more observational data coming out from pregnant mothers that were inadvertently exposed to statins. It does increase the risk of preterm delivery. It does seem like there's less teratogenicity than we initially thought. But this is a very gray area, and this is liable to change in the future. Atenolol, we can have fetal adverse effects, so we do avoid that in pregnancy, and we do avoid that also in breastfeeding. There's also a lot better options available than atenolol, so use better beta blockers is my general recommendation. Now these are medications for hypertension, is what it should say up there. And interestingly, a big randomized controlled trial came out in 2022 called the CHAP trial. And I was really excited to see this. They randomized patients to the top 3 medications out there, labetalol, nifedipine, and methyldopa, to start either at a systolic of greater than 160 or greater than 140. And they saw improved maternal outcomes with starting at greater than 140. So that actually, without any fetal risk. So I was really excited to see that and having some randomized controlled trial data to back up the treatment in this patient population. Hydralazine, as mentioned, can be used for hypertension. It is a second line. It does have a risk of maternal lupus and fetal thrombocytopenia. Methyl-dopa also can cause some maternal hepatotoxicity. So I prefer to use betalol and nifedipine if I can. These do have increased clearance, so you will need to use a higher dose sometimes for these patients. Now moving on to heart failure. So the data, most of the data supports the use of metoprolol. There's really a large body of evidence here. It shows no adverse cardiac abnormalities in the developing fetus. There's some concern with beta blockers for renal dysplasia, but these are safe to use in heart failure patients. It does have increased clearance, so might need a little bit higher dosing as well. If you can't use metoprolol, there's a little bit of data to support carvedilol, but not as much. I would start with metoprolol. For furosemide, there was a large meta-analysis that recently came out showing that the rate of fetal adverse effects were the same to patients that weren't receiving furosemide. But if you look at case series and case reports, you will see some adverse effects to the fetus pop up. But overall, it seems relatively safe to use. If you're using high doses during breastfeeding, that could possibly decrease lactation. But if you're using more lower doses, you can usually get away with it. Digoxin has been shown to be safe to be used in pregnancy. The only little nuance with digoxin is in pregnant mothers, there are these digoxin-like fragments that are floating around. And if you draw a digoxin level, you might be like, oh no, my patient's toxic. It might actually be a false positive high. So you have to be a little bit careful with laboratory interpretation in this population. Unfortunately, our SGLT2s don't have any data for use in pregnancy or breastfeeding, and rat studies have shown a decrease in renal development, so we do avoid them at this time. Hopefully we get more data in the future. And moving on to our last group of medications, this is our coronary artery disease medications. And the first one that we talk about is cholestyramine. So cholestyramine is not systemically absorbed, and so it is deemed safe in pregnancy and breastfeeding. It does lower fat-soluble vitamins, so you do have to replete those if you use that in this patient population. And then we have aspirin. Aspirin's been used for a long time in pregnancy for preeclampsia. We do want to avoid it during breastfeeding because of the risk of Reye's syndrome to the infant. So make sure to not use it there. We would want to avoid use of high-dose aspirin, but generally we don't do that anyway. And if a patient has an aspirin allergy, you could consider the use of clopidogrel. I will say there's a lot less data to support its use in that specific patient population. So in conclusion, we have some data to guide treatment. This is mostly from observational studies. The devil's in the details. You need to read the details when talking to a patient, walk through the specific risks, and consider the benefits to the mother. I think a lot's been mentioned this morning about underuse of different therapeutic interventions in women, and I think by forcing us to read about the risks to the fetus, weighing the benefits and the risks, we can come to better treatment decisions for our patients. More data is needed, and then I just wanted to talk about some quick resources to use in pregnancy and lactation. So there was a recent article that reviewed all the different sources that are out there, and the ones that best meet the new FDA requirements are as number 1 and number 3 on there. That's Briggs Drug in Pregnancy and Lactation. Most of these really good resources are paid, but it's worth it. They have a really great description on all these different medications. And then if you have Lexicomp available, Lexicomp is also available through UpToDate. They use that for the drug information resource. It's the specifically pregnancy kind of additional application in that it has the most complete information to read about. And then there are other various paid and free resources out there, but most likely to get good information, you're going to be using a paid resource. Thank you, everyone.
I'm going to request our exercise physiologist, Belinda Cambodian, to please come and start setting up for the chair yoga that will be offered in the auditorium during the break. And I'd request in the meantime that our panelists, if they could please come up on the stage, we could have Dr. Claire Dubanua, Dr. Aidan Abidov, Chris Giuliano, Tamara Ivers, Susan Masterbrook, Dr. Nancy Masiha, Ryan Rajde, and Dr. Zia Wang. We do have questions from the audience that I want to give the first call to. And then we'll go to the virtual attendee questions.
Questions more for the entire panel. So there's model drug-informed development by the FDA, and a recent example of that is use of IV sotalol. In pregnancy, given the dearth of research opportunities, is anyone aware of the FDA expediting medications, especially new heart failure medications, without requiring, RCT level data, which would be in my mind impossible to conduct?
All right, so great question. So where do I go to descriptive in my everyday practice? Or an example. So really, I have Lexicomp is my primary source that I use, and I have it like engraved in my mind, and I just hit the little jump button and go to pregnancy risk or jump to breastfeeding risk. The amount of time it takes me to click on my app and jump to that specific area is somewhere between 2 to 3 seconds. And then I can just read it. It's not, so it's like 2 paragraphs. So it's not like an overwhelming amount of information. The only thing that's a little bit tricky is that it's observational research, but that's the best information that we have, and we have to make decisions for using the best information that we have for our patients. That's why it's important to involve the patient, say like this is what it says, and it really depends on what you're treating. What is the risk to the mother with the disease that you're treating? What's the risk of not treating it? And depending on the answer to that question, it's going to come down to each individual patient that you're treating at the end of the day. The second part of the question, IV sotalol. And it was more related to could you repeat that part?
I guess it's more of a policy question, right? How are we going to get the new heart failure drugs to our pregnant patients? Because CHAPS was a wonderful trial. I was blown away by CHAPS. But we can't test new heart failure therapies on pregnant patients in a realistic randomized control trial. So I was following the IV sotalol development, which was the model drug-informed pathway. Does anyone know from a policy standpoint or from a drug development standpoint if there is going to be a way to provide more access to medications for the pregnant or the peripartum population?
Let's see if it works. Can you hear me?
Yeah.
Yeah, so the only way that I see, again, it's exceptionally difficult to do a randomized controlled trial, and probably it's not going to happen within the next X years. But what I suggest is utilizing our experience in imaging. We did the same thing with radiation exposure during coronary CTA many years ago. And I urge the representatives of our professional societies to consider keeping nice, neat registries between the centers that already have multidisciplinary teams to collect meticulously all the data available, including results of patient discussion and basically decision making, and see the outcomes. So the outcomes come first. They develop signal on safety or unsafety of particular approaches, and then potentially you can think of randomized controlled trials, if anything. But data registry may be the reliable way to go through approval of some medications. I'm not sure how about the new medications. It's much more difficult process.
I just have a quick question. When we look at risk during pregnancy for valvular lesions, so we always talk about stenoids, but how about right-sided lesions? So pulmonic stenosis, we're seeing more and more patients who have tetralogies, and they have. How do you guys look at that patient, and what is the risk during pregnancy? Do we have to address their pulmonic stenosis before or not? How is the panel looking at that patient population?
So again, you got the stenosis is typically worse in terms of outcomes during pregnancy, any stenosis. However, pulmonic stenosis is something that you should look in consideration of developing hidden pulmonary hypertension if you relieve the pulmonary stenosis, and also look for the multivalvular involvement. If it's single pulmonary stenosis with no significant hemodynamic issues, I probably would either delay the intervention, if it's possible, or essentially plan the pregnancy. Because taking care of pulmonary stenosis is much easier when the patient obviously is not pregnant.
Yeah, and I would just add that right-sided lesions like pulmonic stenosis tend to be better tolerated. And so you may be able to, if the patient doesn't have pulmonary hypertension, I think that's a super important point. The dynamic in the equation changes completely if there is significant pulmonary hypertension. If there is not, then that lesion tends to be better tolerated, and the patient may be able to support a pregnancy without an intervention. And I'd just like to make one editorial comment. In this country, the wealthiest country in the world, we have an unacceptable maternal mortality rate, and largely that is cardiovascular mortality, as Aiden pointed out. The solutions to this problem are not solutions that we're going to find in this room. We know how to take care of patients when they come to us, when they get care. What we need to achieve in our society, which is a political and a socioeconomic solution, is giving those women access to care, making sure that they're enrolled in systems of care, continuing to see women after their pregnancy is over, because we know that a lot of the morbidity and mortality happens immediately after pregnancy, up to a year after delivery. So we need to do better as a society in order to reduce those mortality rates.
I just wanted to add one thing and piggybacking on what Dr. Duvanois just said. Right-sided lesions, we have seen a few at Henry Ford pulmonary stenosis. Sometimes it's a residual of a tetralogy of follow repair. Most of the time well tolerated, but I wanted to emphasize the need to keep an eye on the right ventricle. And there will be a degree of dilatation of the right ventricle that is expected with pregnancy, but we make it a point of following up every trimester, the right ventricle, the BNP level, the symptoms of right ventricular dysfunction, and then during labor also keeping an eye on all the hemodynamic changes, the IV fluid during the epidural, and all those boluses that our pregnant patients will get. And then after delivery, the loss to follow-up is also extremely high rate. And so educating our patients and saying, yes, you got through pregnancy, but don't forget to come back because we need to take care of this. We need to talk about contraception. Don't get pregnant again, within the next few months. So that's also a very important point.
Hi, great session. I just have a couple of comments. One, following Aiden's talk about SCAD or sudden or spontaneous coronary dissection, which obviously we should suspect in young women during pregnancy presenting with troponins. I would caution about using coronary CT routinely in those patients for a couple of reasons. One is branch vessel dissections are not easy to diagnose with coronary CT. I think cardiac CAT has much higher temporal resolution. So if you have the suspicion, it is important to make the diagnosis. So I would definitely recommend proceeding with cardiac catheterization. We have read coronary CTs where we have actually missed SCAD involving smaller branches, which really are beyond the temporal resolution of CT. It can definitely pick up main coronary problems and can be used for follow-up, but I typically would not recommend. I think cardiac catheterization is far superior in temporal resolution. With regards to the question on congenital, I would say barring simple congenital lesions where general cardiology practice can take care of them, I think patients should be referred to adult congenital centers and cardio-obstetrics high-risk OB teams, because there is much opportunity for education for the patient, for future pregnancies, proper imaging, and close follow-up during pregnancy.
Thank you, Dr. And just a great point about SCAD. And I would agree that cardiac catheterization is probably the best way to go, also because it's time sensitive, it changes management. SCAD is like dissection, and while for all of the non-STEMIs we do heparin drip, it's different management, it's no atherosclerosis. You need to stop your heparin drip early on in these patients, increase the beta blockers, do an antiplatelet therapy. We really don't have a lot of recommendation about that. So I would agree with that point.
If I may just, sorry, Dr. David, respond. So as I mentioned in my talk, we should go to most definitive test. And definitive test, it's not just availability of CT, which is difficult in many centers. You cannot find, even if you do it, you don't have great expert to read it, let alone, missing the small vessels, branch vessels. Major thing to me is, now with the development of radial access, it's going to be much less cumbersome to cath this patient. And again, the catheterizer can use only 20-30 cc of contrast instead of fixed machine-based injection of, say, 80 cc of contrast. And also correct level of radiation exposure. It's basically physician-controlled, which is much more reliable and safe. So it's not just diagnostic. Coronary CT advanced, the resolution, upfront resolution of cardiac cath is 0.2 millimeters. Guess what is for the cardiac CT? 0.325. So the resolution, we're getting there. I'm an imager, but I really advocate for use of coronary angiography, invasive coronary angiography, especially if you have real cases. Troponins, chest pain, EKG, don't take a chance.
So, Dr. Lansky, that was an amazing talk, and I've been thinking a lot about your talk, and about having women participate in clinical trials. So when I'm in the, and by the way, we're number 2 in the country in enrolling patients for the spiral on and off med, thanks to our coordinator Yulia, not me, but and also with chemical and radiofrequency in the country, both trials. So we randomize lots of patients. And I asked Yulia just before I came and went to the podium, we have a 33% enrollment in women. The national study, the national trial is 19% women enrolled. And I'm just thinking about how do we do this? Maybe up front, either we put a cap, so when you do the powering of these trials, and it says, okay, you need 600 patients, power the study, and you need to enroll 300 women. And once we hit the target for 300 men, you stop enrolling for men and just only do women. I mean, I've just been thinking about how to do this, how to force this, and maybe with the coordinators, because quite honestly, I'm not going to spend an hour consenting a patient with hypertension when you've got 15, 20-minute blocks. So I'll usually talk to them about it, and then I'll refer them to Yulia to spend more time explaining the protocol. Maybe sometimes it requires the physician to do it. But I'm just wondering on your thoughts as to how do we get over this hump, because we keep talking about it at every symposium. It comes up on and on and on again. It's how do you move the needle on that?
I think your point about capping the number of patients, that's, unless our regulators tell us that this is what we have to do, nobody's going to do it. The sponsors are not going to want to do it, because what it means is you have to extend the enrollment time, right? And maybe your site can do it, many sites don't. And the time and effort that it takes, I mean, the numbers are the numbers, right? This is like, you let the system kind of run, and these are the numbers that we're getting. So I think that to really kind of get the benchmarks, you're going to have to make it a requirement. And then that shifts over to the sponsors to say, okay, well, we need 40% females, and we need 50% females. We're going to have to keep this trial open until we get that benchmark. And exactly as you're saying, I mean, I've thought about this a lot as well. You're gonna have to say, okay, well, we get to half of the patients are male, we close enrollment to male patients, and now we go to female patients. I also think that the concept of stratification, we've never done that based on sex, right? You can't stratify based on everything, but if you stratify based on sex, then you have the true randomization for female and male patients, and you can understand what the outcomes are. Currently, we don't. I mean, the example of danger shock. The problem with danger shock, we're so excited because finally we have, Impella is helping mortality, right? We're seeing mortality difference. 80% of patients in danger shock are male patients. We have 19% females, and when you look at the subgroup in the females, there's no treatment benefit, right? It's a hazard ratio of 1. So does that mean it doesn't work in females? Does it mean that we shouldn't be doing it in female patients? I don't believe that. So I think your point. I think that's where we need to go with this.
Thank you, Dr. Lansky. Great discussion. We have more questions that came up for the geneticist, Dr. Zia Wang from CMU, and for our clinical leads who are doing a lot of cardiac obstetrics at their local locations, and Dr. Claire Duanois. But in interest of time, we'll probably have to move on to the break. It is going to be, we're probably going to get together at 10:15 to resume. There's going to be chair yoga by Belinda Cambodian, who's our exercise physiologist for our Women Heart program. We do Wednesday Wednesday work workouts, which is during noon hour for our patients who get 30 minutes of chair yoga, online class access, which they can do at work. And that way they comply with exercise on a regular basis. So you're welcome to stay here, you're welcome to take a break and go out to our sponsors and visit their booths. Thank you.
Excellent. Thank you so much, Dr. Serene, for the very kind invitation to be with all of you this weekend to visit and be part of this fantastic program. As Dr. Serene mentioned, I'm a prevention-focused general cardiologist and physician scientist at Mass General in Boston. And a lot of my work over the last 5 years is really focused on trying to understand the mechanistic relationship between sex-specific risk factors for cardiovascular disease in women. These are my disclosures. And just to set the stage a little bit for why this is important, and this will harken back to themes you've heard already from other speakers, including Dr. Lansky, but just to try to really hammer home why are these topics important. I like these summary take-home points from the recent Lancet Commission on Cardiovascular Disease in Women. And their key messages included the following: that women with cardiovascular disease remain understudied, underrecognized, and undertreated, that sex-specific mechanisms in the pathophysiology of cardiovascular disease remain poorly understood, myocardial infarction and cardiovascular mortality in this country and worldwide are increasing among young adult and early midlife women, and sex-specific and other under-recognized risk factors, including psychosocial risk factors, contribute disproportionately to the global burden of cardiovascular disease in women. And so, with that in mind, this is a summary figure from a review that one of our star fellows, Anna O'Kelly, led. And if there's sort of one summary figure from the talk, thank you. No, that's better. If there's one summary figure from the talk, this might be it. That we now recognize that there's a host of sex-specific, really reproductive risk factors that influence, or most likely don't causally influence, but predict or reveal long-term risk of cardiovascular disease in women. These include aspects of reproductive history, such as early or late timing of menarche, polycystic ovary syndrome and menstrual irregularity, multiple types of adverse pregnancy outcomes, including the hypertensive disorders of pregnancy, gestational diabetes, preterm delivery, and fetal growth restriction, or small for gestational age. And then multiple aspects of the menopause transition, probably most notably premature age of menopause onset. And I've highlighted these two here, adverse pregnancy outcomes and premature menopause, as sort of the two sex-specific risk factors that have made their way into our multi-society guidelines. So These are the two risk factors specifically highlighted in the ACC/AHA guidelines as risk-enhancing factors for cardiovascular disease to guide the prescription of preventive statin therapies for borderline and intermediate risk patients when you're unsure what to do. And these two areas have also been the primary focus of my research, and Dr. Serene asked for some discussion of mechanisms, so we won't get too mechanistic, but we'll dive in a little bit. I'm going to talk a little bit about how I've increasingly come to think of preeclampsia as really just a cardiovascular condition, both in the short term and as well as for long-term risk. And then I'll say a few shorter words about premature menopause and cardiovascular disease. So preeclampsia is a cardiovascular condition. Just quick show of hands, who's been called by an OBGYN service about a patient with preeclampsia? Okay. That's a majority of hands. And I think it's actually, who feels like that's getting more and more frequent? Yeah. I certainly do at our center as well. So preeclampsia, not a rare condition. The hypertensive disorders in general are not rare. So recent data indicate that 15% of childbearing US women experience a hypertensive complication in at least one pregnancy. And on a global scale, the hypertensive disorders of pregnancy are a leading cause of maternal and fetal morbidity and mortality, to the point that's come up a couple times about hybrid maternal mortality in the US. Now, as a science nerd, I think the pathophysiology of preeclampsia is super interesting. It's also still highly incompletely understood, especially early on. So the early parts are the parts that we don't really understand that well, but there's this cocktail of acquired genetic and immune factors that lead to abnormal early development of the placenta and the placental vasculature. And that's basically subclinical for the beginning of pregnancy, but later in pregnancy that starts to rear its head as the placenta sort of outgrows its blood supply and starts to experience placental ischemia. And this triggers a cascade of badness that ensues, including excess release of these circulating anti-angiogenic factors. You may have heard of SFLT1. This is actually now used clinically by OBs in their triage of suspected preeclampsia. And that in turn leads to systemic endothelial and microvascular dysfunction in mom that then culminates in the clinical phenotype of hypertension, proteinuria, and other clinical aspects of preeclampsia. Now, for most of these patients, blood pressure returns to normal in the sort of first 6 to 12 weeks postpartum, not always. But even when blood pressure normalizes in the early postpartum period, cardiometabolic risk trajectories diverge. And much earlier, I think, than we've historically appreciated, really within the first 5 to 10 years postpartum, these women start to develop cardiovascular risk factors in an accelerated rate. So I really like these data. These data are from the New Mom to Be study. This is a US prospective pregnancy cohort of women enrolled in the first trimester of their first pregnancy. And about half of this cohort of 10,000 women followed up at an average of 3 years postpartum at a heart health study check. And they were age 30, 31 on average at this follow-up visit. Already, 40% of women with a prior hypertensive disorder at pregnancy had stage 1 or greater chronic hypertension. That's a very, very high burden of chronic hypertension in a 30-year-old female cohort. So just to say, and actually some of the other average pregnancy outcomes weren't that far behind. Almost as many with gestational diabetes also had chronic stage 1 or greater hypertension. And this is a population that often falls out of regular, longitudinal care. They're young, they feel okay, they've got young kids at home, life is crazy, and so they're not necessarily thinking about their long-term cardiovascular health, but they're already telling us at this point that they're high risk. And then work that we've done shows that perhaps not totally surprisingly, this translates into an excess risk of long-term cardiovascular events. So these are women from the UK Biobank who enrolled in this prospective population-based UK cohort in midlife, and were followed for up to 10 years in this analysis. And we observed 80% increased risk of incident coronary artery disease events, 70% increased risk of heart failure, and much to our surprise, 3-fold risk of aortic stenosis. And so potentially, really interesting findings. Some of these had been shown before, some of them had not. We were really interested in the heart failure signal, and there's been some speculation that given the female predominance of HFpEF and overlap in cardiometabolic risk factors, that some of this heart failure might be HFpEF specifically, but owing to the limitations of administrative data sets, we can't always tell for sure. But more recent data have shown us, in fact, that there's excess risk of both HFrEF and HFpEF, and that HFrEF is not necessarily ischemic cardiomyopathy, but a lot of this excess risk is HFpEF. So on the left are data from New York and Florida, following a cohort of women for a median 6 years after delivery and showing twofold increased risk of HFpEF hospitalization. And on the right are data that we published from the Women's Health Initiative of women, enrolled obviously much later in life, and again showing twofold enrichment for the hypertensive disorders of pregnancy among women with HFpEF in that cohort. And I could spend an hour with you reviewing some of the epidemiologic associations, but I think as clinicians caring for these patients, what we really want to understand is why do these women with a history of hypertension in pregnancy go on to develop cardiovascular disease, because that informs what we as clinicians do about it. So we've started to answer these questions. Or ask and answer these questions. So in our UK Biobank analysis, we performed something called causal mediation analysis, a fancy statistical approach to try to identify causal mediators, and somewhere between half and 2/3 of the excess cardiovascular risk in women with hypertension in pregnancy appear to be explained by progression to chronic hypertension. So that's a large proportion, and that suggests that that's a risk factor that we should aggressively target in this population, but it's also obviously not the entire story. It's not 100% of that excess risk. I'm a genetics researcher, a large portion of my time, and so we've turned to human genetics to try to better understand some of the causality among these relationships. And just to say, not every relationship, it's not possible to test every relationship or feasible to test every relationship with a randomized trial in humans to prove causality. So one thing we can do is use human genetics as a tool for causal inference to infer causal relationships. You can think of randomly occurring genetic variation in our population as nature's randomized trial. Some of us are randomized to higher genetic risk for a condition, some of us randomized to lower risk for genetic risk for a condition. And so using that causal inference approach, we tested the relationship of 7 cardiometabolic risk factors or traits with the development of a hypertensive disorder of pregnancy, and showed that systolic and diastolic blood pressure as well as body mass index were very strong. Genetically predicted blood pressure and BMI were very strongly and independently associated with a hypertensive disorder of pregnancy, implying that these are in fact causal risk factors for the development of a hypertensive pregnancy complication. And we were, at this point, this was 2 years before the publication of the CHAP trial that you heard about earlier, but we made the claim that CHAP was going to be a positive trial based on these results, and these results would also argue for prospectively testing things like metabolic or weight loss surgery in women with pre-pregnancy severe obesity to reduce adverse pregnancy outcomes as well. Now, many in this room probably know that preeclampsia is a risk factor for peripartum cardiomyopathy, less of a long-term risk, but more of an acute sort of peripartum risk. And this sort of relates back to the pathophysiology of preeclampsia that I reviewed a few slides ago, but we think that some of those key angiogenic factors that are released by the ischemic placenta may also impart bad microvascular effects in the heart, and that might impart some of this excess risk for peripartum cardiomyopathy. And this has been looked at previously really in mouse models primarily, as well as sort of basic description in human cohorts where increased levels of this SFLT1 protein correlate with, basically subclinical markers of systolic and diastolic dysfunction by echo. We asked the question recently in a more pilot scale study, does preeclampsia actually exert acute microvascular effects, coronary microvascular effects in humans? And so to do that, we enrolled 24 postpartum women, 19 with severe preeclampsia, and 5 with normotensive pregnancies, who were on average 2 weeks postpartum at the time of this assessment, and we compared them to a group of 13 premenopausal female, non-pregnant, non-postpartum controls, and we performed cardiac PET imaging in them to quantify coronary microvascular function. And consistent with our hypothesis, we observed that those with preeclampsia had significantly reduced myocardial flow reserve or coronary flow reserve as a marker of coronary microvascular function at 2 weeks postpartum. Interestingly, we weren't really powered to make robust conclusions about the normotensive postpartum group, but if you look at the blue bars are somewhere in between the red bars, which are the severe preeclamptics, and the light blue bar, which is the controls, suggesting that perhaps even normal, uncomplicated pregnancy is also a little bit of a microvascular insult, not something that's really been described before. In the immediate postpartum period, coronary flow reserve or myocardial flow reserve appears to normalize over those first 30 days postpartum, which is good news, and you might think, great, this was a sort of transient microvascular insult, and this will all go away. But we might be seeing an indicator of what's to come if we fast forward 20 years, that there might be enduring microvascular susceptibility in this population. And to sort of start to understand that, we looked at other organ systems that have a microcirculation, and one of those is the human eye. The retinal microvasculature is known to be a now quite robust biomarker of microvascular health and aging. And so we looked among 20,000 women in the UK Biobank who had retinal fundus imaging. We used a deep learning model to extract measures of microvascular health, including retinal vessel or retinal vascular density. And women with preeclampsia had lower retinal vascular health or retinal vascular density, even after you adjusted for every cardiovascular and cardiometabolic risk factor, including blood pressure, arterial stiffness, and other things. So again, suggesting that there might be this underlying microvascular susceptibility that is a risk factor or a setup for long-term cardiovascular disease, including heart failure in this population. Okay, so we've talked a lot about science, a lot of emerging theories about this population. As clinicians, like, what do we do for this postpartum patient in front of us who's just had preeclampsia? How do we counsel them with the data that we have today in 2024? Well, high-quality observational data suggests that doing the basics in this population, things that we know are heart healthy, might be particularly important, including things like maintaining a normal BMI, heart-healthy diet, exercise. And so these are data from the Nurses' Health Study suggesting that women after a hypertensive pregnancy complication who were able to return to a normal body weight postpartum had markedly reduced risk of progression to chronic hypertension compared to those who did not. These data have lent to this emerging notion of the postpartum transitional clinic, which is this sort of model that says the fourth trimester, or that first year postpartum, as you heard, is a really important time where there is continued excess risk of maternal morbidity and mortality, and where we might leverage what we just learned about their pregnancy for education, to change behaviors, to change risk factors, and really bend their lifetime risk trajectories. This is somewhat complicated to implement in our sort of fee-for-service reimbursement system in the US. Who owns this? There's lots of logistical complexities, and of the published experience to date, every system does it very differently. But the core components are finding those who had cardiovascular relevant adverse pregnancy outcomes, providing education and counseling, screening for overt cardiovascular risk factors, appropriately managing medications, including for the purpose of reducing postpartum hypertensive readmissions, and then critically in this population, as I mentioned before, connecting them to longitudinal primary care so that they don't fall out of longitudinal primary care for a decade postpartum. And then for the highest risk, where we learn that they have really, really strong risk factors, things like FH, high Lp(a), secondary hypertension, making sure they get connected with appropriate specialty care as well. What do our guidelines say? Not much at present. There's an AHA scientific statement that says monitor CVD risk factors closely in the first year postpartum. I would sort of argue that's probably neither appropriate for everybody or sufficient, because that's a pretty crazy busy year and you're not always thinking about your long-term cardiovascular health in that time. So that might be a good first step. I mentioned the longitudinal primary care transition already. And then I mentioned the fact that preeclampsia history and other APOs are incorporated as risk-enhancing factors. I would also say, though, that framework, that sort of 10-year risk estimation framework, systematically misses people who have premature events. This is sort of, I think, common sense to us, but we know age and sex are very, very, very strong determinants of 10-year estimated risk by the pool cohort equations or the new PREVENT equation. Pick your equation. Age and sex are the primary determinants of that estimated risk. And so a young woman who has a Lp(a) of 400, a BMI of 40, and a family history of premature events in every first-degree relative is going to still be estimated as low risk in that equation. And so we have to sort of engage in higher level thinking and put all of a patient's risk factors into context. So don't rely exclusively on your 10-year estimated risk is what I mean to say. And then the other thing that the guidelines say about the borderline and intermediate risk groups, as you know, is to consider coronary artery calcium scoring as a further risk stratifier or decision tool. And I just want to highlight these recent data from Sweden. These are the SCAPUS registry. And within SCAPUS, they performed coronary CT angiography in Swedish adults aged 50 to 65. And this analysis looked at those who were women who had had children. And basically, like, the take-home message is that among Swedish women between the age of 50 and 65, 40% with a history of hypertension and pregnancy had detectable coronary athero by coronary CTA, and 10% had a calcium score greater than 100. So age 50 and later is when I start to really think about coronary calcium scoring as a decision tool, particularly in this population. All right, I'm going to shift gears a little bit and talk very briefly about premature menopause and cardiovascular. You're aware of this sort of now robustly reported association between progressively earlier age of menopause and progressively increasing risk of atherosclerotic cardiovascular disease, and for that reason it's also incorporated as a risk-enhancing factor in our guidelines. We wanted to look at this in a little bit more granular detail, and so we used the UK Biobank for this as well, and in this analysis we looked at both premature natural or spontaneous menopause, often called premature ovarian insufficiency, as well as surgically induced premature menopause, which are not always sort of dissected in research or in the guidelines, and looked at the risk of a composite of cardiovascular conditions and then several conditions individually. And in brief, what we saw was a 36% increased risk of composite cardiovascular disease in women with premature natural menopause, and an 87% increased risk in those with premature surgical menopause. And we observed effectively a gradated or progressive increase, as we saw in the previous slide, with higher risks with earlier menopause, relatively higher risks with surgical compared to natural, but that this was not limited to atherosclerosis. And the most striking hazard ratios that we saw in this analysis were actually for aortic stenosis. And I don't know if you can see it the way it's displaying, but for women who had sort of premature natural or surgical menopause, we're looking at hazard ratios anywhere from like 6 to 17. So very, very, very large excess risk of aortic stenosis related to menopause timing, which I think is not widely appreciated in the community. We've looked at multi-omic biomarkers of cardiovascular risk with respect to menopause timing, and we could have a whole other talk on this. I'm just going to highlight one in the interest of time. Leukocyte telomere length is something you all have probably heard of, at least can remember back from med school. Telomeres are these repetitive DNA sequences that stabilize chromosomes, that form a protein complex. And with all of us as we get older, they shorten with age and cellular division. And when they become critically short, the short telomeres induce this sort of inflammatory senescent phenotypic response that's meant to prevent replication of an unstable chromosomal karyotype. But secondarily, that inflammation, we think, promotes cardiovascular disease. And so we looked, again, in the UK Biobank at leukocyte telomere length with respect to age of menopause, and we basically found that with progressively earlier age of menopause, telomeres were progressively shorter, and this was after adjustment for other cardiovascular and cardiometabolic risk factors, and that within women with a history of premature menopause, that telomere length further stratified risk. And there's other emerging areas of multi-omics and genomics that might explain some of these relationships as well. So in the concluding minutes, just a couple sort of high-level thoughts or reflections. How do we move the needle to advance women's heart health? And I say these remarks from the perspective of a prevention-focused cardiologist. But I think the key thing is we have historically ignored cardiovascular and cardiometabolic risk factors in young adults, and especially in women, because we sort of think young folks are low risk. We really need broad clinician education and engagement around this. Cardiologists can't see everybody who's at high lifetime risk. We really need to engage our internists and OBGYN colleagues around this. And I've already given my 10-year risk diatribe earlier, so I won't rehash that. The last thing I'll say is to just make sure you've heard at least once about Jeffrey Rose's prevention paradox, which kind of blew my mind the first time I heard it. And that's the insight that most events in a population, most cardiovascular risk events in a population, occur in folks who do not have high predicted risk. Now this seems counterintuitive because within a high-risk group, their relative risk is by definition the highest, but the issue is the denominator. There's so many people out there in the intermediate, borderline, and low-risk groups that they actually account for the majority of events. And so, implications of this include that we should get smarter about applying certain, rather we should apply certain low-cost, low-tech interventions broadly across the population. Access to healthy food, access to green spaces for exercise, those sorts of things. But also we should get smarter about refining our risk assessment, and asking about reproductive history in women is one way you can very cheaply and quickly do that in the office. So thanks very much again for the invitation.
Again, what's very exciting is the possible link from eclampsia, preeclampsia leading to heart outcomes being microvascular disease, which opens up a whole new paradigm of, are we ignoring ANOCA and INOCA in young population, and should perhaps be more aggressive about diagnosing them and treating them. That would be a great leadway into the next session and the panel discussion. It's my absolute pleasure to invite Dr. Nishaki Mehta to start our case-based panel discussion section. Dr. Nishaki Mehta is an electrophysiologist at Corbell Health. She's a dear friend, a very smart colleague, and I've heard her speak before, and I'm truly and deeply impressed. Nishaki is going to talk to us about palpitations in women.
So the number one reason for visits in the primary care office, in the cardiologist's office, and 16% visits in the primary care office are for palpitations. So when Dr. Serene invited me to speak on this, it was a very germane topic, but the challenge is it's very expansive. So I thought long and hard about what I could convey in, I'm going to shoot for 8 minutes, within 8 minutes, and I think there are 3 major points in this talk I'd like to cover. The first one is, how do we triage palpitations in women? The second one is my focused strategy on diagnosis and management. And then the last part of the talk is, when do you pick up your phone and call your electrophysiology friend for help? So to do this, I'd like to track 2 women who I've seen in clinic over the last 3 years. The first one is a 52-year-old woman with new onset palpitations, and the second patient was a 34-year-old woman with new onset palpitations. And this slide, as simple as it is my first triage strategy. Does the woman have structural heart disease, or does she not have structural heart disease? If she's had no background testing, I need to establish absence or presence of structural heart disease. So my first step was getting an echo. The first woman had a normal echo, and the second woman had an echo with mitral valve prolapse, which in my training I was told is very, very common, is associated with sometimes is associated with anxiety and a subjective sensation of palpitations. That was not my color scheme, but at least it's projecting on Chris's slides. So hormone changes, right? We waxed eloquently about the impact of hormones. Dr. Hanberg did a great talk on the reproductive lifespan of a woman. But specifically to arrhythmias, the image on the bottom left is a really nice example where they used Holter monitoring and categorized the PVC burden in different stages of the menstrual cycle. And they found a significantly, it was borderline significant difference in the PVC burden during menstruation versus during ovulation. So the withdrawal of hormones was associated with a higher PVC burden than during peak ovulation. The image on the bottom right is a patient of mine. So as part of what Dr. Eichen was speaking earlier, we do have a registry at Corbell to look at cardiovascular outcomes in pregnancy and postpartum disease. And this is one of the patients from the registry. This patient, I met her for the first time during her index pregnancy, her first pregnancy, and she had PVC-mediated cardiomyopathy. So the blue graph is the PVC burden. The vertical columns indicate her second pregnancy start and her delivery for her second child. And what we see is, immediately after her first pregnancy, the PVC burden started going down. It stayed flat during her second pregnancy. It started peaking during the time of delivery and the early postpartum period. And it tracked very nicely with the ejection fraction. Where the ejection fraction recovered when the PVC burden was low. And I think this also, we don't really understand the hormone mechanism for arrhythmias, but there is data to suggest that withdrawal of hormones is associated with more palpitations. which is illustrated by these two examples. The other common precipitating factors can be stress, stimulants. The most recent AFib guidelines do not consider caffeine a stimulant for AFib, but it is a stimulant for PACs, PVCs, and all the other kinds of arrhythmias. Iron deficiency anemia. So through the copper registry, not only have we determined that organic causes for arrhythmias, but what we've found is a lot of women who come pregnant with palpitations to our clinics have iron deficiency anemia. And their hemoglobin is spuriously normal, but their iron deficiency studies, iron studies reveal they're very depleted. Repeating it with IV iron takes away their symptoms completely. So I think it's very important to recognize that hemoglobin may be misleading for iron deficiency evaluation in patients with palpitations where every test is coming back fine. Low blood pressure, thyroid disorders. My practice is we get a reflex DSH, and if there are new symptoms and the reflex DSH is not within a year, I do tend to repeat that. Cold medications, especially with stimulants, and asthma drugs, because of the sympathomimetic effects, can flare up arrhythmias. So when we went back and asked the patient what was their reproductive history, the 52-year-old woman was on hormone replacement therapy, which was stopped a week before the onset of palpitations. The 34-year-old woman did not notice any correlation with a menstrual cycle, and she was not pregnant at the time of the clinic evaluation. So this is a basic dictum for all the house staff in the room. Palpitations are subjective. Arrhythmias are objective. Not all palpitations are arrhythmias. Not all arrhythmias manifest as palpitations. So it's very, very, very important to keep this in mind as we go to the next part of the talk. There are different types of arrhythmias: PVCs, PACs, SVT, AFib, and VT. But in order to determine where we stand with a patient, we have to document, but more importantly, we also have to correlate. Because we might find a lot of stuff which may not be clinically relevant unless we can establish the correlation with palpitations. Very broadly, this is what I use. This is actually what I use. This is a video we created for our patients. But devices worn, when I tell them I need to document the palpitations, I offer wearables, or sometimes in some cases like pregnancy in that patient, I offered an implantable loop recorder. The outside wearables are smart wearables or Holter, and my spiel in clinic is that a smartwatch wearable, which I'm a huge fan of, is very good, except it needs patient-triggered activation. So if someone's had syncope, that's not going to help. But if someone has palpitations, go for it. Now, every time they trigger it, it's only going to give me a 30-second snapshot. So in some cases, I do need continuous activation, which is what the prescriptive options on the right-hand side afford us in clinic. So I may start with the Holter and event monitor. If everything comes back normal, I would encourage them to use a wearable. If patients do not want to wear a wearable, then we talk about an implantable loop recorder, but you can see just like a restaurant menu, the dollar sign keeps increasing to the right. So the first patient, we resumed HRT at a lower dose, his symptoms abated, and this was an example of benign palpitations or a reversible cause of palpitations. A monitor was fine. The second patient's monitor came back with sustained VT, and CTA was normal, a treadmill test showed PVCs, and an MRI showed mitral annular disjunction over 10 millimeters. So she was deemed to have the malignant form of palpitations with sustained VT and required an ICD for secondary prevention. My final two slides, consider an EP referral if there is structural heart disease. You'll never go wrong. If there's structural heart disease and there's something wrong, it might warrant a more detailed evaluation, or if there's documented arrhythmias. A modest PVC burden over 10% would be categorized as PVCs requiring an EP evaluation. And this is my final summary slide. I think I'm up on time, but it puts together everything, and the slides should be available to the audience, right?
Yes.
Okay. Okay, all right. Thank you so much for your time. I did not want to overstep my time. Thank you.
Thank you, Dr. Mehta. That was outstanding. Please can I request Dr. Monica Jadu, she's going to talk to us about chest pain in women, MVT, Minoka, and SCAD. Dr. Jadu is an interventional cardiologist at Corbell Health. Monica, we look forward to your talk.
All right, perfect. Thank you so much. It's an honor to be here to talk to you today about chest pain in women. Special thanks to Dr. Serene for inviting me to be here with you today. I'm going to quickly give you two cases and quick takeaway points about SCAD and Minoka. We'll start with the 34-year-old female. She presented to the hospital with 30 minutes of chest pain. She said the pain was severe and radiated to her back and jaw, and it was associated with nausea and vomiting. It worsened when she laid flat and improved when she was leaning forward. Her medical history is significant for a cesarean section that was performed 1 week prior. Otherwise, no family history of coronary disease other than a paternal grandmother who had an MI over the age of 55. She didn't smoke, did not use any illicit drugs. When she came into the emergency room, she was noted to be hypoxic with a pulse ox of 87%, and she appeared to be in respiratory distress, and she was tachypnic. Her laboratory studies were significant for just a leukocytosis and a mild anemia. Her high sensitivity troponin was mildly elevated at 24, and her BNP was elevated at 212. You can see her initial EKG showed sinus rhythm. Her T waves looked a little peak. They ordered an echo and a cardiology consult, and her chest pain persisted, so 30 minutes later they repeated an EKG, and this is what she had. As you can see, she had ST elevation, so the cath lab was activated. When she went to the cath lab, you could see that her right coronary artery appears normal, and when they took pictures of the left, you could see staining in the left anterior descending artery, and it's highly suspicious for spontaneous aortic dissection. An LV-gram was performed. Although the left ventricle didn't fully opacify, you can appreciate some hypokinesis, and her LV-EDP was elevated at 34. There was an echo that was performed, so I'm just going to show you those images. You could see her EF was definitely reduced, and you could see hypokinesis of the apex, anterior wall, and anteroseptal walls. So the decision was made to go ahead because she was still having chest pain, she still had ST elevations, and the decision was made to go ahead and intervene on the LED. An impella was placed for support. The LED was wired. Using a microcatheter, a distal injection was performed to show that they were intraluminal. IVUS was then also performed to assess the size of the LED, and then it was stented. Post-intervention, you could see nice angiographic result. IVUS was repeated, and unfortunately it did show that the dissection extended into the left main and also, left main and into the circumflex. But at this point, her ST segments had resolved and she was chest pain free, so the procedure ended at this point. She did have a cardiac MRI that confirmed a reduced ejection fraction, and late gadolinium enhancement was consistent with transmural infarct. There was mention of an LV thrombus, but as you could see in the echo, we didn't appreciate that. She was treated with goal-directed medical therapy. 3 months later, she had a repeat echo performed. EF was 4, I just showed one image here. You could see the anteroseptum looks a little bit better, but her EF was still at 40%. My second case is a 60-year-old woman who presented to the emergency room with chest pressure, heartburn, epigastric pain, nausea, and vomiting. She did have an upper respiratory infection about 2 weeks prior, but she was symptom-free for 2 days before she presented. I apologize, I have hyperlipidemia twice, but she had hypertension, hyperlipidemia, and a history of uterine cancer that had been treated. She was a non-smoker, no significant past medical history that contributed. In the ER, she was found to just have hypertension. Her exam was otherwise benign. Laboratory studies were normal other than her troponin, which was 1742, so quite elevated and consistent. At this point with the EKG with the non-STEMI, as you could see, she didn't have any ST abnormalities. So she too was taken to the cath lab, and as you could see, she has very tortuous vessels, but there's no occlusion noted or significant stenosis. And then a picture of the right. Her right looked normal, but had an anomalous takeoff from the left coronary cusp. There was a question after the procedure was ended as to whether or not something was missed. Maybe there was an obstructed vessel, and so she underwent a coronary CT angiogram. Oops, I guess I should show that LV-gram. You can see some focal hypokinesis in the mid-inferior wall. Here's her echo. Overall, the ejection fraction is preserved. Some hypokinesis of the basal inferior wall here. And as I mentioned, she did have a coronary CTA, confirmed normal coronary arteries, and a benign course of the anomalous right coronary artery, which came off the left cusp. She did undergo a cardiac MRI where her ejection fraction was normal. Late gadolinium enhancement was most consistent with ischemia as opposed to myocarditis. So just some takeaway points from these two cases. The thing about multivessel disease, MINOCA and SCAD, is that they all present the same. Chest pain or pressure, lightheadedness, dizziness, shortness of breath, excessive sweating, excessive fatigue. So it's hard just based on symptoms to decipher between all three of these. And coronary angiography is really the best test to do in order to help us decide what's actually happening in these patients. With SCAD, there's certain features that we look for, such as a radiolucent line in type 1, and with type 2A and type 2B, you could see normal segments with an abnormal segment in between S and B, and with C, it could be throughout the whole vessel. Sometimes you can be fooled. It can look like atherosclerosis when it's actually a dissection, or it could be confused for coronary vasospasm. So with SCAD, you have to have a high clinical suspicion, as with our patient. Early angiography, and then if it's classic features like with our patient where there was staining, then it's SCAD. And if not, you can consider additional testing or provocative testing, like giving intracoronary nitro to see if it's vasospasm, imaging with IVUS or OCT to see if there's plaque rupture. Treatment for SCAD really depends on whether or not there are any high-risk features. In our patient, she had persistent ischemia, ST elevation, so PCI is considered appropriate. Most cases, when they're stable, we just treat that conservatively with no intervention. With MINOCA, as you know, it's a working diagnosis. People rule in for an acute myocardial infarction, undergo coronary angiography where there's no obstructive disease. The key is to make sure there's no alternative diagnosis. So we look for coronary, cardiac, or extracardiac causes. As was mentioned, there's 5 to 10% of all MIs are related to MINOCA. It's important to diagnose this accurately because there is a 3.5% one-year mortality. And the things to consider is myocarditis, Takotsubo, and sometimes people have normal myocardium, which is true MINOCA. And just as I mentioned, I know I'm out of time here, look at the angiography, check the echoes. Intracoronary imaging could be extremely useful in these patients, and when we don't find that, we need to look for other extracardiac causes, demand ischemia, anemia, PEs, things like that. And the treatment really just depends on what caused it. So that's really it. Thanks.
Dr. Jadot, this is great. I know the SCAD patients in case 1 are always a nightmare, and then when they have that thrombus intramural, you have to go. You saw that long stent that went proximal because you really want to cover the distal and the proximal edge, and they have more late apposition issues, and it's a disaster. So that was a great case. Also with MVD, microvascular dysfunction, MINOCA, imaging modalities are critical, and there's testing in patient and outpatient, and MRI is critical within the first 2 weeks. Please can I invite our panel discussants, Dr. Karthikeyan, Anantha Subramanian, Dr. Nathan Foster, Dr. Nicholas Haddad, Dr. Sunil Rao. Please can I also invite Dr. Zia Wang on the podium and Dr. Claire Duanua. Thank you.
With 21 runs of non-sustained VT, the challenge is whether it actually truly is a part of the MVPS contributing to the PVCs and non-sustained VT from the surgical standpoint, because the question for us is, do these patients get surgery regardless of the extent of mitral regurgitation? Many of these patients actually may not have severe MR.
They don't have, I have a couple of patients, I'm getting this diagnosis, and these patients are reading online that they need a defibrillator, and I'm trying to figure out, is it the PVC, is it just an incidental finding, or is there a correlation between VT or non-sustained VT in this diagnosis?
There appears to be, I think MRI is crucial because many of these patients with MAD tend to have papillary muscle fibrosis and infralateral fibrosis, which is where PVC origins can come. But the challenge with ablation and other things in these patients is the PVC morphologies are multiple, so ablations typically are not very helpful. And if they clearly have sustained VT, as was discussed, or multiple runs of non-sustained VT, then potentially they qualify as malignant syndrome, mitral valve prolapse syndrome, which may require an ICD placement. The challenge with my patient from 2 days ago is, does she warrant surgery to correct the disjunction despite no MR? And I think it's up to us to make sure that the patient doesn't clearly have MR, so a transesophageal echo, etc. needs to be done to ensure that the MR is not severe to be able to correct.
What I would say, he was asking if we operate on these patients. I do a lot of mitral valve surgery. So we do see these patients, they're real. You'll do monitors on them, they'll have 15% PVCs, and those patients, we really worry about them. Usually you can localize where the arrhythmia is coming, which papillary muscle or not. One of the ways that we're addressing, we'll do a mitral valve repair and I'll ablate during the operation the papillary muscle, and sometimes EP has to come back. The ones that have no MR are the problem, because we don't know if we correct the MR, are we going to reverse this fibrosis? And the question is, by the time that they have all this arrhythmias, is that fibrosis? The idea is that this pulling of the cord is making the tip all fibrotic, and that's where the arrhythmia comes. So if I fix the mitral valve, is that going to reverse it? So we don't have data for that, but it is rare, not rare. Patients that have really bad prolapses, we'll test these people. We'll put them on a bike, we'll exercise them. We want to show for sure that they have no MR. Because a lot of times you just put the probe and you don't see it, their blood pressure goes 20 points, and all of a sudden that leaflet, all it has to go is 2 millimeters up and you have severe MR. So we really, really test these people, and most of the times we'll find that they have MR.
The other point I do want to quickly make is that although the traditional definition of MAD is 10 millimeters or greater, it is a continuum. There are patients who have 3-4 millimeters up to 6 millimeters who may not traditionally qualify, who also come under the spectrum of MAD. So I think it is an evolving continuum. Obviously 10 millimeters or more clearly identifies a high-risk group, particularly with VT.
Yeah, but to me it's almost like a new entity. I mean, I didn't study this when I was in my fellowship, and I'm getting these reports now, and I'm just not sure what to do with it.
No, absolutely. But I think, as was Dr. Rodriguez mentioned, I think this is not a new entity. Actually, there is descriptions back from 1960s and 70s about similar things, and histopathologically it has been shown that there is clear separation of the posterior leaflet from the annulus. I don't know if you have a comment.
And the other thing is, we know people with severe MR, they're sudden death, and we never understood why do people with severe MR have sudden death. And if you look, it's this patient population that, is a 60-year-old who had MR for 10 years and they have sudden death with no coronary disease. We think is related to this. So this is all backwards. But this weekend we're going to be watching.
No, I think the take-home point is not all MVPS patients are benign, because we sometimes dismiss them off saying, oh, it's mitral valve prolapse with a little bit of palpitations. There is MVPS and then there is malignant MVPS. So we need to make sure that we're not missing that subgroup.
Thank you. There's a question for Dr. Zia Wang. She's the geneticist from CMU about peripartum cardiomyopathy and genetic evaluation.
So for a genetics perspective, there is always high penetrant single gene causes. So there is one mutation and it is inherited in the pattern, and there's very, very high risk of having the disease. Well, on the basis of that, the background, there's actually a lot of polygenic etiologies that multiple risk factors could work together. And so in that case, we are only, at this moment, we're only able to find the high risk cardiomyopathy, including the dilated cardiomyopathy and hypertrophic cardiomyopathy. So there is a significant overlap between the population of peripartum cardiomyopathy with the dilated cardiomyopathy. there was only like probably less than 10% of them, if you test them, to find those currently known monogenic etiologies for DCM for these peripartum women. So that's really the situation. Obviously, if you do find it, and that is definitely going to benefit the whole family from that the genetic perspective.
Thank you, Dr. Wang. There's one more question, and this is for advocacy, and we have Dr. Sunil Rao here, about advocacy for heart health in women. What are the new horizons that we should be on the lookout for?
Thank you so much. And in regards to mitral annular disjunction, actually last year there was a bill that was proposed by the senator from Kentucky. Actually, he found his wife dead when he came home. So that actually improved the access to valvular heart disease in that big section. So just a pitch that it's important that we advocate for these patients, because these are the entities that are under-recognized or not recognized, which is what ACC is trying to help to advocate for statewide and also improve access to women in cardiology. Thank you.
Any questions from the audience? Dr. Anand, microvascular disease, there was discussion today about the potential of correlation and perhaps eclampsia, preeclampsia, particularly in women who are disproportionately affected by it, leading to heart outcomes. And at this time, I'm sure you deal with this as well, when we see these women with chest pain, the pathway that we take, typically getting a PET scan or getting a CAT for MVD study becomes somewhat challenging. In your opinion, what would be the best way of dealing with young women with chest pain so that we are able to effectively diagnose MVD early on?
Thanks, Nisha. That's a huge population, and I know both of us collaborate on this on a daily basis. I think the key thing is to be able to arrive to the diagnosis early, and so we all know that CAD is now a spectrum, which means it's not only epicardial disease, but it's coronary microvascular disease. So just getting a CT alone CT is very helpful, because as Dr. Abido pointed out, the negative predictive value is fantastic. So I would definitely say, if there is not another test which would answer the question, for example, in the form of stress echo or nuclear, I always think about radiation in young women, so I'm always hesitant, but the current CT technology is so advanced, you could do a coronary CT with close to 5 millisieverts with advanced processing, which is less than nuclear scans, etc. So by doing the coronary CT, you're excluding epicardial disease. But that's where the problem starts, because most people then tell patients, your chest pain is not from the heart, you're done. So therapy decisions go down, coronary disease evaluation and chest pain evaluations go down, and that's the biggest challenge. Is we need to go to the next step, because something is causing the chest pain, and we have not still excluded microvascular dysfunction. So the best available test non-invasively, short of invasive testing where we need to put catheters in and measure IMR or give acetylcholine for vasoreactivity, which can be done as a gold standard, but cardiac PET with flow is the best. And obviously, I'm passionate about it because I do it daily. But it is the gold standard for non-invasive flow reserve, and is able to define, as shown just a few minutes ago, stress and rest flow and flow reserve. And so typically flow reserves less than 2.5 in young women. Even though we use a cutoff of 2, most young women, or young men for that matter, should have coronary flow reserves of 3 to 4. So just having a 40-year-old woman with a flow reserve of 2.1 or 2.2 already signals that there is a kind of a potential problem there. And so PET is very valuable. So when you combine anatomic and physiological imaging, that nails down and rules out potential microvascular dysfunction, so that you can then investigate non-cardiac causes of pain.
If I just get a cardiac PET.
That's a great point, Dr. David. So when we talk about ANOCA, angina with non-obstructive coronary arteries, or ischemia with non-obstructive coronary arteries, Microvascular dysfunction is one of the subtypes of it. And 60% of those patients, however, will have vasospastic testing. So when we bring these patients to the cath lab, we do 3-step testing. We have to make sure they have no epicardial disease. And the first step of which is the IMR testing. We do bolus thermodilution method before, after adenosine infusion, and look for CFR value and IMR value. CFR less than 2 and IMR more than 25 as diagnostic. The second step is that we look at any myocardial bridge during that study, which may have been missed. And for that, we have to do RFR evaluation, which is a diastolic parameter of any significant hemodynamic across that myocardial bridge. And the third step is vasospastic testing, which is a different animal. 60% of patients have vasospastic angina, and we diagnose it epicardial or microvascular. If you see epicardial decrease in the coronary vasculature by 90% with incremental doses of infusion of intracoronary acetylcholine, patient has chest pain, you have EKG changes, you've established epicardial spasm. But if there is no epicardial decrease in the vessel diameter, but the patient has chest pain, EKG changes, that's microvascular spasm. The reason we have to delineate between the three is because they are treated differently. If patient has a myocardial bridge, you cannot give them indoor, it's going to worsen it. But the patient has spasm, you can't give them beta blockers. So it helps us decide. In fact, there are papers looking at giving intracoronary doses of different medications and assessing response and treatment in these patients. So to answer your question, Dr. David, I'm going to bother you. That's no problem.
I actually had a two-part question, but I want to be mindful of everybody's time. So I had a question for Dr. Anand. So as a first-year fellow, echo is intimidating on its own, but in terms of thinking about pregnant patients, are there any must-know pitfalls in terms of interpreting echoes for fellows? And my second question was for Dr. Foster. In just thinking about atrial fibrillation and pregnant patients, are there any special considerations that as fellows that we should know in terms of beyond anticoagulation and their impact on the fetus, but also the timing of intervention in terms of getting them back to sinus rhythm? Is there any special consideration when it applies to pregnant women?
So to answer your first part of the question is, yes, you should know, and the key thing is knowing what is normal in pregnancy, as was already discussed. So there are multiple physiological changes of pregnancy which will change cardiac structure and function. The key thing is mild four-chamber dilatation, increased stroke volume. So your cardiac output, your gradients may all be slightly elevated, but your diastolic function, strain, everything should be normal. So once you know the normalcy, you may have mild leaks in valves in relation to the pregnancy. So these are all normal changes which we shouldn't get excited about, just like in clinical examination, a physiological S3 is common in pregnancy, mild tachycardia is common in pregnancy, etc. Only when we know the novel variation, we can actually diagnose what is truly abnormal. And so echo is a great starting point with no radiation, as long as we know how to interpret it correctly.
I think as far as atrial fibrillation goes, first of all, the presentation may be palpitations. We've seen an excellent presentation on palpitations in women. High index of suspicion is the first place to start. Obviously, you want to make that diagnosis, you want to eliminate structural heart disease, and you want to do some ambulatory monitoring. And so if you do make the diagnosis of atrial fibrillation, then you have obviously the consideration of protecting that patient from stroke. I would lean heavily on our pharmacy colleagues as far as that those choices go. And as my colleague and co-fellow Dr. Abadoff pointed out, cardioversion is perfectly safe, and I think restoring sinus rhythm and symptomatic atrial fibrillation is paramount.
Just two quick questions to the panel. So first question, probably to Dr. Foster and maybe anybody else who wants to contribute. So what should be our approach to the young lady that is planning to get pregnant and needs ICD? any specific device, any specific way of implantation? Does she need to have ICD after pregnancy? The second question also to the panel, and maybe I would appreciate a specific response from our geneticist colleague. What is the practical approach to somebody who is phenotype negative and genotype positive for the peripartum cardiomyopathy?
As far as ICD goes, I think my bigger concern would be what is the underlying pathology for which the patient needs the ICD. There's no magic in ICD implantation. Obviously, in someone who is pregnant, the concern would be exposure to fluoroscopy in the lab, and you would have to drag me kicking and screaming to the lab to do that in a pregnant person. Again, I think the bigger risk to the mother and to the fetus is what is the underlying pathology? Or is cardiomyopathy? Is it
Primary prevention.
Again, primary prevention? I would most likely wait until after pregnancy.
Yeah, so that was a very good question about, if we suspect that there could be genetic etiology for the cardiomyopathy and peripartum, and the patient tested negative, what we do about it. So there's two layers. One of them, I assume that you have excluded a lot of other non-genetic etiologies, but there's still a very rich background of genetic etiology, but those are not monogenic, high-risk single genes. In regards to that, the treatment is going to be based on per the clinician's discretion. But in the meantime, if we're considering family history, sometimes that could be still very significant for the rest of the family members. If you ask them if there is a multiple family members had early onset cardiomyopathy, and they do need the entire family, especially first-degree relatives, they should be recommended to undergo asymptomatic cardiac evaluation at relatively early on, just in case there's a significant genetic factors. Hi everyone, I'm curious as to what the panel thinks about preeclampsia and diastolic dysfunction, because we do know that preeclampsia does increase the risk of heart failure with preserved function, cardiovascular disease in the future, but how about short-term parameters for diagnosing diastolic dysfunction? We've all seen a patient who goes into pulmonary edema, elevated BNP, hyperclentic range blood pressure, but then the LV function is normal, our diastolic parameters are normal. Should we change our criteria to diagnosing diastolic dysfunction in pregnant women? Is there a role for strain or anything else we should be looking at to say this is preeclampsia, one of the manifestations of preeclampsia just in a diastolic physiopathology?
I'll take the first stab at it. So all of us who read echoes know that it is a nightmare, even on a normal day, to read diastolic dysfunction. So there is really no strong correlations consistently between echo and cath. Even the current guidelines, at most the correlation on a good day is moderate, around 50 to 60%, and unique physiological or pathological scenarios pose challenges to echo diastolic function. So personally, I will give you my opinion. I use strain extensively. When diastolic parameters don't fix, our lab routinely does LV global strain, RV strain, as well as LA strain. So I think left atrial strain is valuable because it gives insights, assuming that. And if there is a reason, and I'm not talking about the sick patient, we all know that even the subset of HFpEF patients, about 30% of them can have normal diastolic parameters with proven HFpEF. And so doing exercise diastolic evaluation is actually key. Rather than do invasive, we can start with exercise diastology. We actually, all 100% of our patients in our lab with shortness of breath get diastolic stress testing. So we do ischemia followed by we do baseline parameters followed by that. So I think doing exercise diastology, incorporating strain analysis along with traditional parameters, and looking for the other thing I would tell Reem is that I think when we read the parameters, people actually do not focus on the actual numbers. They look at the ratios. We know that, for example, if a 40-year-old woman, their E primes are 7, that is actually abnormal. Even though the numbers may come out okay, because there is age-related normal parameters for diastology. So those kinds of small clues may help, but I would be the first to admit sometimes we may need to say it's indeterminate and we don't know what the actual diastology is. I'd be interested in getting other feedback.
Thank you, everybody. In interest of time, we are going to take a second break. We do have dietary demonstration during the break for whoever's interested. We are going to resume back at 11:45 to listen from Nadia Sutton, who is an interventional cardiologist coming in from Vanderbilt. She is the Director of Interventional Cardiology Research at Vanderbilt University Medical Center and Assistant Professor, Department of Biomedical Engineering at Vanderbilt, and chairs the Society for Cardiovascular Angiography and Innovations for Women in Innovations Committee for SCI, and also Associate Director of Journal of American Heart Association. Thank you to our panelists for being here, and thank you to you all. See you after the break. The international keynotes lecture is going to be recorded and sent over to everybody via email. We will probably need to make this a full-day conference to accommodate all the panel discussion and participation. Dr. Maya Sarhal is here, who's an interventional cardiologist and endovascular interventionist at Mass General Hospital and Associate Program Director of the Peripheral Interventional Fellowship there. She will be speaking after the poster judging. So I would urge you to stay there, and after her presentation we are going to announce the winners for the posters. The first prize is $500, and second prize is $250, and third prize for our participants. Lots of residents and fellows have put in a lot of effort into it, so we appreciate our judges taking the time and giving the input. At this time I'd like to invite Dr. Nadia Sutton, who is an interventional cardiologist coming in from Vanderbilt University Health Center. She directs the research for interventional cardiology there and is an assistant professor. She chairs the SCI WIN committee. Dr. Sutton is going to talk to us about VTE and HIT.
Can you hear me okay? Oh, can you hear me okay? Yes, okay, great. All right, well, thank you so very much for the invitation to be here. It is such a pleasure to be back in Michigan. I know that it's very bittersweet for Nishta, but I, for one, am very excited that she's moving to Nashville. She's going to be my neighbor, and I consider her my friend, and I'm just really delighted. And again, thank you for the invitation to be here. This has been a really wonderful symposium, and just so much energy around women's heart health, and it's very inspiring, and I appreciate the invitation. So the topic of my presentation is about hormone replacement therapy and venous thromboembolism risk. And as I was kind of thinking about the topic, I was thinking about the fact that during my training, even though I was very obviously interested in women's heart health, this is something that we don't really talk about that much, and so I feel like it is very possible to go through all your training as a specialist in cardiovascular medicine, and honestly probably leave your training without having really that much information about what we should be telling our patients as it relates to this question. So here are my disclosures, non-relevant to this presentation. So I just wanted to start with a case, and then we can kind of think about this individual as we kind of go through some of the background information, and then I'll wrap it up with some general advice that we might be able to give to a patient like this. So this is a 54-year-old woman who is 2 years into menopause and is seeing you for a preventive cardiology visit. She has palpitations, insomnia, urinary tract infections, and a decreased libido. She is obese with a BMI of 30.5 and has hypertension. Her ASCVD risk score is intermediate, 6%, and she wants to know if she can take hormone replacement therapy for her symptoms, her menopausal symptoms. So, just some background. So obviously with, about half of the population being women, we have, millions of postmenopausal women out there. These are questions that come up very frequently. And, just to kind of review some of the symptoms that people can experience in the perimenopause time, which are irregular cycles, fluctuations in estrogen and progesterone, with decreased estrogen causing a rise in follicle-stimulating hormone, can last for many years, but pregnancy is still possible in the perimenopausal period. Menopause is defined as having no period for a year. The estrogen and progesterone are no longer actually produced by the ovaries, and this is associated with an increase in FSH, which you can actually be tested for. And then premature menopause, which we've already kind of discussed, is associated with increased cardiovascular risk, which is defined as occurring at age less than 40. Occurring at age less than 40 and has the same symptoms, but also is, in addition to increased cardiovascular risk, is associated with increased risk of cataracts, periodontal disease, and osteoporosis. So, talk a little bit about some of these symptoms. So hot flashes, night sweats. Okay. Do you want me to go back through it? Just joking. Okay. Anxiety, palpitations, insomnia, and mood and cognition can be affected with this idea of sort of a brain fog. You could have thinning of the hair and skin and nails, and vaginal dryness, atrophy, and urinary tract infections, and associated with decreased libido. So a couple of, I'll try to emphasize a couple of points throughout this presentation, but one of the key points I want to emphasize is that hormone replacement therapy is not the only answer. Ultimately, women can have some relief of their symptoms or manage their symptoms with lifestyle modification, so strength training to sort of decrease the risk around the osteoporosis, reducing alcohol to improve sleep quality and improve stress control strategies can be helpful. Nutrition is important in terms of potentially thinking about making sure you're increasing your protein intake and making it more of a plant-based diet. Potentially, nutritional supplements can be helpful. Although this is not something that I've prescribed, there is the potential or opportunity for some individuals who prescribe bioidentical hormones that have been compounded to adjust the doses. And then you could potentially obviously consider adjunctive therapies like acupuncture or hypnotherapy. So, what does hormone replacement actually mean? So there's two hormones that are we're mostly talking about two different hormones, estrogen and progesterone. As far as systemic estrogen, it can be administered in several different formulations. It could be oral, it could be transdermal, as a spray, a gel, or a vaginal ring. And then progesterone can be administered in similarly different methods, so including a transdermal combo patch with estrogen and IUDs and things along those lines. So why are we even worried about using hormone replacement therapy? And I think that this study, the Women's Health Initiative, which was published in JAMA in 2002, has really had a very far-reaching impact on use of hormone replacement therapy. So this really important study included over 16,000 postmenopausal women who were between age 50 and 79, who had an intact uterus at baseline, and they were randomized to receiving equine estrogens plus medroxyprogesterone acetate or a placebo. And I do want to point out that equine estrogens is not the formulation that we're using today. And then the primary outcome was either coronary heart disease, which included non-fatal myocardial infarction, and coronary heart disease death, with invasive breast cancer as the primary adverse outcome, and then there were some secondary outcomes as well that were looked at. And as you can see on these graphs and these Kaplan-Meier curves on the right-hand side, there was actually an increased risk of coronary heart disease, stroke, pulmonary embolism, and invasive breast cancer in women who received hormone replacement therapy. There was a decrease in colorectal cancer and hip fracture, but ultimately these sort of other key endpoints really strongly influenced the field to sort of shy away from prescribing hormone replacement therapy for women, thinking that we're increasing their risk. So because of this study, from 2002 to 2008, there was actually a 50% decline in prescription of hormone replacement therapy. I do want to point out that the Women's Health Initiative average age of enrolled patient was age 63, suggesting that these women were actually sort of well into menopause at the time that they would have started on these therapies. And I'll talk a little bit, but there's a couple more sort of details that we can kind of think about that may modify our sense about risk in this patient population, including how are we actually administering the hormones, and then the timing of when we're actually starting them for patients. So there's a couple of studies that occurred subsequently that I think kind of help us with timing and the way we administer the hormones that could potentially sort of alter that risk-benefit ratio and make it potentially more beneficial for women. So this study, for example, the vascular effects of early versus late postmenopausal treatment with estradiol, looked at over 600 women, and then they were stratified by them being sort of early postmenopause, so less than 6 years after menopause, or if they were more than 10 years after menopause. And then these women received estradiol and a vaginal gel plus progesterone or a placebo. And they looked at an indicator of atherosclerotic coronary artery disease, an indicator of atherosclerotic disease in terms of it being carotid intima media thickness, as well as coronary atherosclerosis by coronary CT scan. And what they found was that for the individuals who were early postmenopause, that there was a reduced rate of carotid intima-medial thickness in the group that received hormone replacement therapy versus those who received placebo, but that benefit was not seen in those who started the hormone replacement therapy more than 10 years after menopause. So ultimately, we think that this hormone replacement therapy could be more beneficial from the standpoint of atherosclerotic disease if it started earlier, but the benefit is not there if you start it later. So what are the contraindications to actually, what are the current sort of sense of contraindications to use of hormone replacement therapy? Well, one is the history of breast cancer. If we think the individual is already at a high risk of venous thromboembolism, if they have unexplained vaginal bleeding, and if they have an otherwise high risk for atherosclerotic disease because they've got a history of myocardial infarction, stroke, or their ASCVD risk score is greater than 7%. And then an intermediate risk individual might be somebody who has some risk factors, but maybe they've never had an event. They may have sort of an intermediate ASCVD risk score, whereas somebody who's low risk would be somebody who's less than 60, has a low ASCVD risk, is otherwise healthy, and has no personal or family history of any venous thromboembolism or myocardial infarction. So this is another key point, which is the route of administration is an important determinant, and then that prostaglandin, so the use of prostaglandin with estrogen can also potentially modulate the associated venous thromboembolism risk. So this is another study that was published a few years after the Women's Health Initiative that looked at, it was actually sort of a case control study, but what was found was that for women who were using estrogen in an oral formulation, they were actually 4 times as likely to experience a venous thromboembolism event versus those who were using estrogen in a transdermal formulation. And then also the type of prostaglandin that was being used was actually also important for the risk of venous thromboembolism. And then I also just wanted to quickly touch on just a couple of things. One is that there is a consideration about whether or not testosterone therapy could be potentially helpful for women postmenopausal, especially for sort of hypoactive sexual desire. symptoms, but ultimately, we don't have any long-term studies for safety in women, and it's considered off-label use at this time. And then just to sort of reemphasize this recommendation for integrating different approaches, so potentially using hormone replacement therapy in the context of other types of behavioral interventions, physical interventions with exercise, dietary interventions, and biostimulatory interventions can overall improve patients' experience and make them a bit more functional. And then there's also some other potential pharmacological interventions that would be non-traditional in terms of things like Swedish flower pollen and maca. So just coming back to our patient initial presentation, this was a 54-year-old woman who is a couple years into menopause, and she's has these risk factors of being obese, but her ASCVD risk score is sort of intermediate. I don't know what your initial thought was when you heard about this patient, if it was that you thought we wouldn't, recommend hormone replacement therapy, or if we should. But ultimately, it's sort of an individual patient, discussion. But she seems like somebody that actually would be pretty reasonable to consider it for. She's considered to be intermediate risk. She has significant symptoms, and I think that things that could be helpful to her would be to give her some advice about the fact that if she wants to start, this would be the time to do it, because you get the most benefit earlier on. If she was to wait, she might not be able to derive as much benefit from hormone replacement therapy. And that if she decides to use hormone replacement therapy, that we should be recommending a transdermal formulation of estrogen along with progesterone. And then we also would want to be recommending other types of interventions for her, including diet and exercise and potentially behavioral therapy that could also benefit her. So that's all I have.
Thank you, Dr. Sutton. That was a great presentation. We're going to move on to panel discussion. Please can I request Yulia Abidov, Dr. Kila Duvanua, Harni Lakshman, Dr. Kila Ramaswamy, Dr. Sunil Rao, Dr. Lekha Richardson, Dr. Robert Sasser.
If I could just offer a brief summary. Nadia, that was a really great overview. And I think what's important to consider is the context. Back when WHI came out and the HERS trial just before that, I think we really swung the pendulum too far against hormone replacement therapy in menopause. And so we were wholesale taking women off of their HRT and really maybe causing needless increase in menopausal symptoms that could have been avoided with a little bit more thoughtful and nuanced approach. So as you outlined with your case, I think we need to consider what the symptoms are, what the underlying risk is, and then very importantly, the route of administration, as you emphasized. Aside from, so the transdermal approach really is the safest, both from a lack of increase in risk of VTE, and then also you don't see the rise in triglycerides that you otherwise would get with oral estrogen administration. So those are the things that I think are really important to consider. And let's think about what we're trying to accomplish. Primarily what we're trying to accomplish is relief of symptoms. I don't think that we should primarily be administering hormones for some supposed risk reduction, because there are other ways to achieve that are probably more substantial and better. But for relief of menopausal symptoms in a woman who is perimenopausal or recently postmenopausal and has a low risk profile for breast cancer and for cardiovascular disease, it's very reasonable to consider postmenopausal hormone therapy with the right route of administration.
Thank you, Dr. Duvanua. I think the timing is also important.
So I have a question for Dr. Duvanua and Dr. Sutton. So a patient with stable coronary disease, and we face this sometimes in reality, who had a stent 5 years ago and has remained stable, but markedly symptomatic postmenopausal woman symptoms that have defied all low-risk therapy and over-the-counter preparation. She remains markedly symptomatic. Is this an absolute no, or is that a shared decision-making risk-benefit discussion?
So Nadia, I don't know what you're gonna say. I would say I would try really hard to avoid hormones in that patient. I would consider vaginal cream estrogen, which would be lack of systemic effects, and potentially other medications which have been shown to be moderately effective for relief of menopausal symptoms, but I would try to stay away from systemic HRT.
Well, I would do what she said, but I think that it is a really big, question, because we're doing more and more non-invasive testing, so we're detecting things like mild atherosclerosis and coronary calcium in patients that previously we would have just said they don't have any disease, but now we know they do. So the question is, like, what is the threshold for when we think the patient is too high risk? I mean, I guess that's a big question that I still have.
Hello, my name is Olga Montesola. I'd like the panel to touch base on duration of hormone replacement therapy and cardiovascular indications for discontinuation of someone who is on therapy and comes with diagnosed with new disease.
I can address that. As an internist, this is what we talk to our patients about on a day-to-day basis. I really try to limit a patient to 5 years, and I'm always having a discussion with them at each visit on what their symptoms are and how they're progressing, if it's helping, if it's not, because we're always trying to wean them off. I don't continue it. Some patients say that the brain fog and some of those things are really cleared by using some of these HRTs. Those would not be reasons that I would continue these patients on their hormone replacement therapy. But usually my timeline is within 5 years, I'm having a very strong discussion with them about whether we should continue or not.
I would also like to open this question up to you, Dr. Sasso, as to what your thoughts are on hormone replacement therapy.
I would say considerably controversial with this audience. I should preface this by saying several things. One is I'm thoroughly convinced that menopause is a hormone deficiency state. It should be treated as such. If you take umbrage with that and want to discuss it, I can certainly discuss it with you, but I really believe that modern medicine with vaccines and the work that you folks do, et cetera, has given women 30 years of additional life. It was only in 1850 that life expectancy was 56, now it's 80 for women, and that's 30 years of estrogen deficiency. If you look at, we heard some earlier talk about how, we only have observational data, We have a lot of observational data, and we have decades of it, and all of it has shown cardioprotection. It's interesting that if you look at the Nurses' Health Study, which was started in 1976, this was over 100,000 female nurses between 30 and 59. They followed them for a very long period of time, and 10 years later, their risk of a major cardiac event was, relative risk was 0.5. Their risk of stroke was not increased, and there was a small increase to VTE, and this was all with oral estrogen. 40 years later, we have a Cochrane meta-analysis of all of the RCTs, which said there's a 50% reduction in major cardiovascular events, no increase in stroke, and a small increase in VTE. So observational data can be very good if there's a lot of it and if it's well done. WHI, I think, has a lot of good information in it, none of which was presented in 2002. All of those relative risks for things like cardiovascular events, which was like 1.6, and breast cancer 1.3. If you look at the adjusted confidence intervals, they all straddled 1. None of that was significant, statistically significant, nor is it particularly clinically significant. But if you look at WHI, and if you look at the Nurses' Health Study, and if you look at HERS, there's a first-year blip of increased cardiovascular events, which continues to decrease year after year. By year 6 in HERS, WHI was like 0.6. So I do definitely think there's a role. as primary preventative therapy for cardiovascular disease with long-term use of hormone replacement therapy. And as far as route, you have to look at other things, because yes, I do think you definitely decrease the risk of VTE when it's transdermal, but only oral estrogens have been shown to significantly decrease the risk of diabetes. And we talked earlier about how significant that is. Even WHI showed a 24% decrease in new onset type 2 diabetes in patients who were taking oral estrogens, and better glycemic control than those women who already have the disease. So my thoughts on this is, now estrogen could be lifelong. And maybe you start initially with oral therapy in those patients who are at increased risk for diabetes, et cetera, transition them to lower doses and then transdermal. But I think HODIS, in the light of all of this controversy, and after WHI published a paper, and he's a professor of internal medicine, and he was the head of atherosclerotic research in USC, and he published a paper saying we should be considering this as primary preventative therapy for cardiovascular disease. And I think for good risk women, for taking this long term, there's very strong evidence that there's a substantial decrease in cardiovascular events, no significant increase in stroke, and yes, if you take it orally, a small increase in VTE with a relative risk of something like 1.7. So those are my thoughts.
Thank you, Dr. Sousa. This is definitely a very, very controversial topic. We tend to comply with the guidelines at this time, which recommend the 60 years turn-up, and the timing of starting it is critical with the symptoms, which probably was a fall from the WHI as well, the timing of when it was started. But again, this is very controversial, and that is what makes it a really good discussion point. Any questions, Irene?
Actually had a question for Dr. Sasso. So with all the data that was out there, they said the cardiovascular benefit is only for patients who are between 50 to 65, but there is no clear cardiovascular benefits while using a hormone replacement therapy over the age of 65, or the data has not been clear yet. So if somebody is 65 and if they have already had a risk of thrombosis or had a VTE in their prior life, in their prior years, then wouldn't that be a contraindication?
Excellent question. So let's back up here just a little bit. Estrogen, if it decreases the risk of a major cardiovascular event, is because it protects a healthy vessel. Increases nitric oxide, increases distensibility, it increases TPA and decreases PaI1, all of which is good for a healthy vessel. If you already have atherosclerotic plaque, especially with a necrotic core, and markedly increased metalloproteinases like you do with oral estrogens, you probably destabilize that plaque. And that's why we keep seeing these first-year rises in major cardiovascular events that significantly decrease by year 2, 3, 4, etc. So the Cochrane review I just talked about was for women who were less than 10 years out from the menopause, showing a 50% decrease in cardiovascular events, no increase in stroke, and a small increase in VTE. So yes, you're absolutely right. When should this be started? Really should be started in the perimenopause, and then early menopausal and continued from there, because it's protecting healthy vessels. It's going to do nothing for atherosclerotic plaque that already exists. It may actually destabilize it early on. The best work for this is Tom Clarkson in cynomolgus monkeys. And he took monkeys and he gave them an atherosclerotic diet and took out their ovaries and then gave them an atherosclerotic diet plus estrogen, and there was a 70% decrease in coronary artery stenosis. He then took them and put them on a healthy diet, took their ovaries out, put them on atherosclerotic diet plus estrogen, 50% reduction. So how you go into the menopause is really very important. Then he put them on a healthy diet, took their ovaries out, waited 2 years before starting hormone replacement therapy. And 2 years in a cynomolgus monkey is like 6 in us, in humans. And then started them on estrogen, and there was 0% reduction in atherosclerotic plaque. Well, that's WHI, isn't it? It's that, yes, we have to start it early. The patients who benefit the most is at the time of the perimenopause, menopause. And if you're more than 10 years out from the menopause, it's probably a bad idea to start that They're certainly far less beneficial if we're talking about cardioprotection.
So I think as you started your comments, you're gonna get a lot of pushback from this audience about the idea or the concept of lifelong postmenopausal hormone replacement therapy as being beneficial in reducing cardiovascular risk. I definitely think there are points of agreement in what you said about the timing of estrogen administration, the benefit for symptom relief, and potentially also benefit in terms of reducing atherosclerotic burden if hormone replacement therapy is given early and is given through a transdermal route. That's another point where I would disagree with you. But as Nishta said, this is a controversial topic, and I think what's really important is shared decision-making with the patient to discuss their symptoms. I think for this audience, we're not going to agree with you that there is lifetime benefit for cardiovascular disease prevention.
I hear that loud and clear, but we can't put the blinders on with regard to cardiovascular prevention alone. Long-term use of hormone replacement therapy with regard to osteoporosis and decreased colon cancer, decreased incidence of macular degeneration, etc. There are multiple other healthcare health functions that are improved long-term with hormone replacement therapy. Now, if anywhere along the line here, they become a poor candidate for hormone replacement therapy due to cardiovascular risk factors, by all means we have to reconsider it and stop it. But there are many patients, I think, who remain reasonable candidates lifelong, as long as we change the route, go transdermal, decrease the dose. It has other benefits, including sexual function and vaginal atrophy, etc. So it has to be looked, like everything, it has to be looked at individually. Each patient, every year, when they come back, we look at the risk factors, see what's being benefited and what isn't, and decide if and when it can be continued. But
I think the point is well taken. It has to be individualized, and we have to take a collaborative approach when we take care of these patients, because it continues to be a very controversial topic at this time. Any other questions on hormone replacement therapy that we have from the audience? Dr. Nand.
I'm curious to hear from the panel and maybe even Nadia with regards to how would you approach SCAD, fibromuscular dysplasia, or inherited aortic syndrome patients who are on hormone replacement therapy or who desire hormone replacement therapy? Is there any evidence for or against those patients?
I'm not aware of any good evidence. I would want to not give exogenous hormones to a patient with a history of SCAD.
Any comments, Nadia?
I think it sounds like an area that needs further study.
I would agree with that too. Any other questions on hormone replacement therapy? If not, because we do have Yulia here, and one of the points that was brought up during Dr. Lansky's presentation was about enrollment of women and the disparity, and Yulia works hands-on with them all the time. I'd love to hear from you, Yulia. How do we, in a practical world, increase female representation in the trials? Because that seems to be the way to create the evidence that we need to take better care of them, no matter what the topic is.
I'm happy to report that sponsors started really to implement strategies to recruit more women. We have current study that we are doing that we actually were notified that sites that do not recruit enough females will be capped to continue to recruit male participants, and sites that do recruit females will get extra support to do that. But when we heavily rely on investigators to refer us more patients, but female patients. But as a research team member, I would say we should go more to community events to educate about research participation. We should probably participate in family fair events, spread awareness about research studies are going on. And when another topic will be is patient retention. to recruit patients, it's half work. We need to make sure patients are staying in the research study. So when we consent them, especially female patients, we really point on, what are our expectations from their participation and try to listen what they expect from participating in the study. We lay out follow-up period for patients, what they should contribute to the research. We explain them actually how negative is impact for the research, them to withdraw from the study. And we also try to negotiate within a budget some incentives for patients, maybe not even patient stipend, but to compensate child care if needed or elderly care. It's become really difficult because we are not allowed to pay patients to participate, but this is all we can do, and if any suggestions, we will take them.
Thank you, Julia. You have been a part of research trials, enrollments. Any comments on how we can increase female participation? Any more questions from the audiences? Because if not, we will move on to our next brief break, and then we're going to get together for Dr. Maya's talk. Thank you. Bye.
People in the U.S. Are affected by venous thromboembolism a year. There's up to 100,000 deaths per year due to this, and 10 to 30% die within a month of diagnosis. About a third have long-term complications, and about a third have recurrence within 10 years. So this is a serious problem. There's a variety of options for therapy, ranging from anticoagulation to placement of filters in patients who can't tolerate anticoagulation. And now there's many toys in the cath lab that we can work with: aspiration, thrombectomy, catheter-directed lysis, and pharmacomechanical catheters. It's a very exciting time to be a peripheral interventionalist. So why do we need advanced therapy? We need to intervene early to make enough of a meaningful impact. I think one of the biggest challenges, humbly put, like for me, in any of the PE trials, is identifying patients who are high risk is very, very challenging. Whether it's, there's this whole new entity of normotensive shock now, recognizing elevated lactates in patients and really just not relying solely on vital signs. I think they can be very deceiving. And imaging, I think, has really brought this to light with RV dilation, et cetera, and recognizing who's going to do well and not has always been challenging. So I think despite the fact there's a lot of new ongoing clinical trials, I think we're going to still be left wondering what the right thing is to do for these patients. And I think it's identification of who's high risk. So why does this matter in pregnancy? Between 2011 and 2013, about 10% of pregnancy-related deaths in the U.S. are due to PE. This mortality is too high, and I think there's many ways to treat this safely now. And I think we really have to make a lot of effort to advance therapy in this area. So thrombotic risk, I won't belabor this point too much. I think all of us know this Virchow's triad. We learned this at some point in time in medical school. If there's hematologists in the room, they understand this much more than I do. There's a lot of venous stasis, IV cable compression, iliac compression. There's procoagulant factors, reduction of anticoagulant activity, and fibrinolytic activity reduction. So I want to bring this up because I think until I did vascular training, I was completely unaware of this, and maybe other folks are a little smarter than me. Venous thromboembolism risk is throughout the pregnancy, but highest in the postpartum state up to 6 weeks. I think we sometimes forget this, but I think it's super important for patients who've had a prior VTE, particularly related to pregnancy. How do you manage them for their second pregnancy, and kind of recognizing these patients even when they come in postpartum. I'm going to briefly mention this because I think this was discussed in a lot of detail earlier today. As in all of medicine, I feel like we're recognizing this more and more. There's major disparities. The people who do worse are Black men and Black women in terms of PE-related mortality. Additionally, in the last decade, there's been a rise in deaths despite advancements in therapy. I don't really completely understand that. I don't think any of us do, but it's just something we need to be cognizant of. We're missing something in the management of these patients with pulmonary embolism. So I think part of the challenge is when people are pregnant, all these things we look for in PE and DVT are present. People are tachycardic, they're dyspneic, they've got elevated respiratory rates, they have elevated D-dimers, what's normal, what's not. I think this leads to a lot of challenges in terms of diagnosis. For DVT, leg edema, leg pain, elevated D-dimer, these things all exist in pregnancy. So trying to figure out what's normal and what's not normal is I think, very challenging. I'm not going to review this in too much detail. I think this is worth review for anyone who manages these patients, but there's the years criteria. They basically try to create an algorithm for patients who are pregnant and incorporate symptoms, D-dimer, and imaging in terms of trying to make a diagnosis of PE efficiently. And I think it's a reasonable algorithm, and like many algorithms, I think it's pretty intuitive. But I think it's a helpful guideline when we're starting to think about this. So I want to mention this. I think a couple folks have alluded to this already today. Radiation exposure, I think we all worry about pregnancy and women who are pregnant and radiation exposure to the fetus. I think we need to kind of step back and think about what's at stake if we don't make a timely diagnosis. And the radiation exposure is relatively low. Okay? In the first trimester, it's a bigger deal. But after that, it's relatively low. I don't want to admit this, but I will. I thought VQ scans were much lower radiation. It's actually much higher. So CTPA is a reasonable, efficient thing to do during pregnancy. Talk to the patient about the risks, but if you're concerned, you need to make a diagnosis. So these are numbers just to be a little bit more granular. The fetal risk is negligible if it's under 50 milligrams. Okay, so there's 0.17% conceptive loss. So that's very, very, very low. And just going back to my numbers, the CTPA is anywhere from 0.01 to 0.66 milligram. So again, the stakes are high in these patients if we don't make a timely diagnosis. And I've definitely seen a lot of delay, frankly been part of the reason for delay in the care of these patients because I was unaware of this. So DVT, I'm just gonna try to talk about DVT alone and pulmonary embolism. So why is anticoagulation alone not sufficient? Okay, it does not prevent clot propagation. It doesn't reduce the risk of pulmonary embolism. Okay, it does prevent clot propagation and does reduce risk of pulmonary embolism. It does not resolve clot. It doesn't prevent valvular dysfunction. It doesn't reduce the risk of venous hypertension and doesn't rapidly resolve symptoms. It does not prevent post-thrombotic syndrome, which is a real entity that can be associated with a lot of morbidity and reduced functioning in society and a lot of cost to our communities. So the open vein hypothesis is intuitive. An open vein is good, reduced valve damage is good, and reducing venous hypertension reduces the risk of post-thrombotic syndrome. So what is post-thrombotic syndrome? For folks who are unaware of this, I think this is the worst version of post-thrombotic syndrome, venous ulcers. This is the most common long-term complication after an acute lower extremity DVT. As an interventionist, I would say it is 1,000 times harder to deal with chronic DVT than it is to deal with acute DVT. I would rather do 10 acute DVTs compared to 1 chronic DVT in the cath lab. They're much more challenging to deal with. Post-thrombotic syndrome is poorly understood, like I mentioned earlier, but it definitely reduces quality of life and increases healthcare costs. These patients, as you can imagine by looking at this slide, need frequent visits to wound care, need leg elevation, and need to be relatively immobile to allow this to heal. So a lot of what we do is based on data from almost 20 years ago. So there's the Cabin trial and the TRACK trial that I'm going to kind of briefly summarize and mention why I don't think they're valid anymore or are incredibly limited. So Cabin was an open label randomized control trial. They enrolled about 189 patients. They solely enrolled iliofemoral DVT. They randomized patients to catheter-directed therapies versus anticoagulation alone, and they looked at post-thrombotic syndrome at 24 months. And they also looked at iliofemoral patency, and they looked at some secondary endpoints that I'll go through in a moment. So what did they find? There was a significant reduction in post-thrombotic syndrome in patients who had additional catheter-directed therapy, 41% versus 55%. They went the extra mile and looked at patients who had regained iliofemoral patency, and there was a significant reduction in patients who had iliofemoral patency, so about 37% versus 61%, okay? And a p-value of less than 0.001, so obviously statistically significant. So safety, there were about 20 bleeding complications, about 5 clinically relevant bleeding, and 3 major bleeds, and notably there was no intracranial hemorrhage. Post-thrombotic syndrome I've mentioned, and they did 5-year follow-up, and the number I want to mention is the number needed to treat is 4. There's very little we do in medicine with the number needed to treat is 4. And these are relatively, I think in the grand scheme of what we do in a cath lab or in IR suites, this is a relatively simple intervention. So what I take away from this is patients with iliofemoral DVT and a low risk of bleeding, consider something else. So the TRACK trial was published about 5 or 6 years later. They enrolled everyone with proximal DVT. So they enrolled patients with iliofemoral DVT and FemPop DVT. They use devices that are not, I would say they're not used anymore, but used less often now. They use angiojet, trellis, and catheter-directed thrombolysis. And they found that there was no difference in the incidence of PTS. And there was a higher incidence of major bleeding, about 1.7 versus 0.03%, though no intracranial hemorrhage or fatal bleeding. They did notice that there was a lower BCCS scale and Villalta scales, which are to assess post-thrombotic syndrome, a greater reduction in leg pain and swelling. But when they did a subgroup analysis looking at patients with iliofemoral DVT, there was definitely a reduction in post-thrombotic syndrome in those patients, about 18% versus 28%. But I think in large part after the TRACK trial, I feel like the iliofemoral DVT space was a little stunned. And what I take away from both the TRACK and Cabin is that patients with iliofemoral DVT should be considered for intervention and can be considered in patients who are low risk. And there's many, many additional therapies, thanks to a lot of companies that have worked on this in physicians, that we can use now to treat iliofemoral DVT safely. I think some of the concerns that have been raised time and time again about the TRACK, it was a multi-center trial. The volumes at each site were low. As with anything we do, the more we do, the better we get at it. There was a variety of therapies used, angioplasty, infusion catheters, different doses of lytics. They used the trellis device, which is no longer used, and there was concern that this attributed to valvular damage that potentially made post-thrombotic syndrome worse. And there was a very low percentage of patients stented. I can say in my practice that a lot of patients tend to have May Thurner's that you can find on IVIS, so I wonder how much that contributed. And our standards, frankly, for use of intravascular imaging have changed so much in the last 10 years. So now what? I would say, like I said, iliofemoral DVT is different and than femoral popliteal DVT. Not all forms of vein recanalization are equal, and we really need new research to assess new technologies. I will, for the nerds in the audience who read vascular ultrasound, I would just mention this, just so everyone is aware. Most labs only go up to the common femoral vein. So you have no way, when you get a venous duplex scan, to recognize if someone has external iliac vein DVT unless you look further and actively look above. So whether that's ultrasound in your lab, whether that's CT, I think it's valuable when you do not know the proximal extent of a DVT, and it's just not required by high cable at this point. So catheter-based options. I know this isn't an interventional talk, but I'm an interventional junkie, so I apologize. So catheter-directed thrombolysis, percutaneous mechanical thrombectomy, and then pharmacomechanical catheter-directed thrombolysis. There are many catheter-directed thrombolysis catheters. What seems to have kind of taken over the US market is ECOS. It has this additional ultrasound technology thought to improve clot breakdown with TPA infusion. There's a variety of thrombectomy catheters. I only have experience with a handful of them, probably more than I should have experience with. The penumbra catheter is a suction thrombectomy catheter for anyone who does interventional cardiology. It works the same as it does in coronaries, except it's a bigger catheter. The challenge is it doesn't really know the difference between clot and blood perfectly, although they've changed their equipment quite a bit in the last several years to try to modify that. So the biggest concern with this is blood loss. ClotTriever in the legs is, a bigger device and literally manually extracts the clot. It's this cage-like thing to the right. And then there's AngioVac and now AlphaVac by AngioDynamics, which is kind of a funnel-based system that works really well on large clots. There's JEDI, which I have very little experience with, and a cleaner, because they don't work, just we don't use them often in our lab. So we also have percutaneous mechanical thrombectomy. I think this is a very interesting technology, particularly the Bashir catheter. There's a lot of new data on Bashir, and I know they're actively enrolling in PE trials right now. This is a catheter that has a basket on it. The basket opens up in the clot and is thought to infuse TPA and a deeper penetration potential and break down the clot in a more effective way. So what's on the horizon? I'm really looking forward to this trial. This is the Defiance trial. It's by Inari. They're looking at how well ClotTriever treats iliofemoral DVT. And I think they're looking at post-thrombotic syndrome severity at 6 months. And I think this is hopefully going to change the way we approach these patients. So I'm going to briefly talk about a case. This was actually my first thrombectomy case as an attending. So this patient's 41 years old. She came in with severe left lower extremity pain and swelling and some back pain. She's G3P2. She's 37 weeks pregnant in 2 days. Her labs essentially all look normal, aside from an elevated D-dimer. Her leg is enormous. I don't think this is normal. I've been pregnant before. I have big legs, but not quite like this. She had a venous duplex scan. I apologize, I'm a non-invasive doctor too. So they looked, I'm just showing you the common femoral vein and the left common femoral vein. These were both compressible, trust me on this. But on the left side, there's this thing called rouleau formation. There's very monophasic flow. There's almost no flow over there. And this was read as no DVT, amongst other things. But I think the bottom line, what they saw and what the primary team saw was no DVT. And this patient urgently had to go to the OR that night for a C-section. And I heard about this case at 7 or 8 p.m. And I'm like, my God, she's got a proximal DVT and they're completely unaware of this in the OR. So hours after she came out of the operating room, I asked them to do a CT scan. And as you can see, I'm sorry, the image quality is not great, but there's a cable thrombus and there's common iliac vein dilation on the left. Okay. I asked them to repeat the venous duplex. And as you can imagine, now there is clot in the left common femoral vein, and there's no flow in the common femoral vein on the left side. And she had thrombosed her entire limb. Okay, this was hours after leaving the operating room. So, she was incredibly symptomatic. You know, I find phlegmasia to be a very challenging diagnosis to make. It's what I tell the cath lab when I want a case to get done that they don't want to do. I can get patients to move faster. This was a very challenging case, I think, for a variety of reasons. We do a lot of these cases prone. You can't take a patient who just had a C-section and make them prone. It's mean, and it's painful. So she also had cable clot, so we needed to think about ways to proximally protect the patient from embolization. We ended up going in through the neck, putting in a 24 French sheath, protrude sheath in, and then coming in from above and taking out all the thrombus, or most of it. This is the protrude sheath. It's a temporary filter. It's a really cool device. As you can see over here, there's a bunch of clots sitting there in the iliac vein and distal cava. Got a ton of clot out, and this is what it looked like afterwards. I also have to say, I know a lot of these trials have looked at post-thrombotic syndrome at 6 months and 24 months. In my experience, these patients feel better within hours. I think and if they don't, in general, I'm worried something was not effective about my treatment. So PE, the fun part. Again, so many treatment options: anticoagulations, filters, thrombolytics, surgical embolectomy, ECMO. And ECMO is very up and coming, and I think we're using that as a adjunct therapy to a lot of what we do. So there's a lot of evidence to support intervention in treatment of intermediate high-risk PE. So this is a meta-analysis that was done to determine the mortality benefit and bleeding risk of patients who got thrombolytic therapy versus anticoagulation alone. And what they found was the risk of 6 versus 0.6 versus 0.6 versus 0.6 significant benefit here that was statistically significant. And when they looked at major bleeding, there was obviously a difference between patients who received lytic therapy versus not. A brief timeline of management of PE. I think this is very similar to stroke and very similar to MI, I think, in terms of the natural history of how we've kind of approached this. So initially, there was a lot of studies with regards to lysis, and we have now transitioned over to looking at thrombectomy and maybe a combination of both to manage these patients. Weighing kind of the risks and benefits of thrombolysis and aspiration, I think catheter-directed lytics, there's an increased risk of major bleeding. There's a delayed time to improvement of symptoms, particularly in PE. I worry about this in the hemodynamically unstable patients. Historically, we needed an ICU stay. I think this is changing a little bit with things like the Bashir catheter, shorter duration lytics. I'm young, as many of you can tell, and I haven't been doing this that long, but I can remember as a resident these patients sitting in the ICU for 12 hours or 24 hours. We don't do that anymore. We do 4 or 6 hours of lytics, and generally we found that that's sufficient. Aspiration thrombectomy, there's a risk of PA and cardiac injury. I think that risk is very low. There's a theoretical risk of dislodging things and moving things more distally and precipitating decompensation. There's resources for folks who are at centers where the cath lab does this. When I do this and I'm on STEMI call, that means my STEMI patient's going to wait in the emergency room. That's something I have to think about. We don't have 2 call teams at Mass General. And there's a learning curve. These are big catheters that you are manipulating across the right ventricle, and not regular right ventricle. It's an enormous, big right ventricle. So it's much harder to do, and it requires some skill and training to do it, I think. So I'm going to briefly talk about, some, I think, landmark trials in pulmonary embolism. So the ULTIMA trial showed a reduction of RV to LV ratio. This looked at ECOS and catheter-directed thrombolysis in patients. There was no significant major bleeding, and there was an increased risk of minor bleeding. This is the Optilice data that I kind of briefly alluded to. This I think has changed our approach to catheter-directed lysis. I think in PE and in DVT, and frankly a lot of what we do when we talk about thrombolytics, we found that lower and shorter doses of TPA are effective at treating pulmonary embolism. And this was a study where they looked at different doses of lytic therapy and different durations of therapy. And low doses are effective at treating some of these patients. So I think depending on who your patient is, what your concern is, and frankly, and sometimes, this is crazy to think this, but the time of day the procedure is getting done, it affects their decision making in terms of what dose I think we use. The Thrombolex catheter I think is quite promising and an interesting catheter. It's unique. I think there's this basket associated with it. They're doing a current trial, and I apologize, I can't recall the name of it, where they're using the Bashir catheter just for single kind of pulse spray TPA. and a cath lab to see how effective that is at treating PE. I have to say, in my practice, for the proximal stuff, I tend to want to do thrombectomy. For the really distal stuff that I think I'm going to have trouble getting to, I tend to do more lysis. That's just my way of thinking about it. The major bleeding risk, when you look at a series of trials kind of put together, is about 4.3% with lytics, and intracranial hemorrhage is about 0.7%. So that's why thrombectomy exists. So Extract PE is a trial that focused on the penumbra catheter, and they found a significant reduction on RV to LV ratio of about 27%, and a reduction in systolic PA pressure. Again, I think these are very hard things to measure. I think we've all seen patients who've gotten suction thrombectomy. I've noticed a significant drop in their PA systolic pressure, but their RV to LV ratio is the same. And then 2 weeks later, they're fine. I think which value to take into account is unclear. The FLASH registry, I think the biggest thing for me that I take away from the FLASH registry, in addition to significant improvement in PA systolic pressure, is that it was safe. There were only 1.8% major adverse events, and there was a reduction in hospital stay in these patients. So I think that's very, very, very important, particularly in young people. And then more recently, there's angiodynamics that I think most people know AlphaVac, but there's the AngioVac catheter. There's an AlphaVac catheter that now has, over the last 6 to 12 months, been approved for pulmonary embolism. In their trial, the APEX AV trial, there was a mean decrease in the RV to LV ratio of about 0.45, and there was about a 35% mean clot reduction looking at the modified Miller score, which is just one way we measure thrombus burden. So there's a lot on the horizon, and I'm hopeful, but a little skeptical that any of these trials are going to tell us exactly what we need to know, because I think we still lack an understanding of what a high-risk pulmonary embolism is and who we should be targeting. The HYPE-PYTHO trial is looking at lytic therapy, ECOS and anticoagulation versus anticoagulation alone. They have very, very stringent criteria in terms of enrollment. The RV-LV ratio has to be greater than 1 and an elevated troponin. Systolic blood pressure of less than 110, and an elevated respiratory rate and an elevated heart rate. They're still actively enrolling. The PureList study is focused on the Inari device, and they're looking at intermediate high-risk PE, and looking at FlowTriever and anticoagulation. This is led by Jake Geary and Mae West. And PE Track, which I think is the big one for me, is looking at catheter-directed therapies plus anticoagulation, whether it be lytics versus thrombectomy versus anticoagulation alone. And I think this will be a really, hopefully, informative trial in terms of telling us what to do with patients. They're looking at a variety of primary outcome measures, including peak oxygen consumption at 3 months, NYHA classification, and 6-minute walk tests, SF36 scores, and incidence of clinical deterioration. And I think the other marker that they're looking at, which I think will be really helpful, is cost effectiveness of catheter-directed thrombectomy versus thrombolysis therapies in general. So I'm just going to briefly review a case. This, in the interest of full disclosure, this is Kenny Rosenfield's case. I have not had to take care of a pregnant patient in shock with PE yet, primarily. This patient's 43 years old, she's 39 weeks pregnant. This was a case from about 6 years ago, and I think it illustrates how I think we would have managed this patient differently even today. She came in with shortness of breath with minimal exertion. She was lightheaded and dizzy and pre-syncopal on admission. Her vital signs were notable for an elevated heart rate and a low oxygen saturation. Her NT-proBNP was about 1800, and her high sensitivity troponin was quite high, 238. I don't think you need to be an echo reader to recognize that the right ventricle here is huge. The RV systolic function is impaired. And I think this is the definition of a saddle pulmonary embolism. It's coming up slowly, and there it goes, a very, very large pulmonary embolism. So we had a PERT activation many, many years ago, and a variety of treatment options were discussed. Anticoagulation, percutaneous removal, cardiac surgery, and discussed kind of the timing and mode of delivery. The patient got acutely sick, not the patient, the baby got acutely sick, had D cells and was taken to the OR emergently for a C-section. Intraoperatively, as you guys can imagine, she got sick, but we were prepared, or they were prepared for it back then. The ECMO team was on standby, cardiac anesthesia that was there, and she got cannulated for VA ECMO. And she was taken straight to the cardiac cath lab and underwent thrombectomy. Back then, I think angiovac was primary catheter being used. There's a lot of clot. We like to show these pictures off anytime we do thrombectomy. I love showing these patients, or showing these pictures to patients. And as you can see, there was improved perfusion in the image to the right of the screen. And fun one, all the clot we got out. So a lot of clot effectively taken out during a thrombectomy case. So I think, to me, when I asked Ken Rosenfield for a case for the purpose of this presentation, I was like, would you do things differently now? And he kind of paused, he's like, I don't know if I would. And I think just given how far we've gotten, I suspect if there were any concerns about this patient, I think we would have probably taken her to the cath lab sooner. And this is an illustration in terms of how much has changed. I think these procedures have gotten safer. There's many devices on the market available, and we can tailor a therapy for these patients. The cath lab does not, or IR, or vascular surgery, whoever's doing these, it does not have to be a scary place for pregnant women, and I think recognition and understanding that these therapies exist is really, really important. I can say in the last week, I've done a thrombectomy case, and I had the cardiac anesthesiologist say, I had no idea you did this. I'm like, shame on you for saying that. Of course we do these cases. So we do them. These are wonderful, and I think they really have lasting impacts on patients, and I can speak to my first year as an attending. I think every present I got was from a DVT case I did for my patients. It really affects their life long term. Leg swelling is a really, really big deal in these patients and can really affect their morbidity long term, though not mortality, and PE, obviously mortality. Okay, so this patient was off pressors, weaned off of ECMO, extubated, and Kenny still sees her in clinic, and she looks wonderful. So multidisciplinary teams are very, very important, particularly when you're dealing with pregnant patients. I love PERT, it's wonderful. I think it helps us justify areas of gray in medicine. It's really helpful to have multidisciplinary discussions. And I think it also helps enroll in clinical trials, which I think is the only way these things are going to be reimbursed in the future. It's very hard for me clinically to want to enroll some of these patients, but I think it's important because that's the only way we can justify doing these procedures in 5 or 10 years. No one device is great for every scenario. And thank you for your attention.